Good evening, everybody, and welcome to the program of UROMET, which is being conducted by the USI and the Indian School of Urology. This was earlier a physical one, which was a simulation training at Gurgaon facility, but due to the pandemic, we were unable to do. We did one in March, but because of this pandemic, we have not been able to do that physically. But nevertheless, we thought we need to continue with the training virtually. We could do this, and the faculty have put in a lot of effort to get this program, and it's been designed for the residents. I hope all the residents would benefit with this. With the changing times, this is very essential because there is growing patient expectations and the litigations, and there are very few opportunities for our trainees to train themselves well, not like earlier where we would say see one, teach one, and do one. But that's not possible now with the increasing number of uh, postgraduate seats. You would not be able to train them adequately, and simulation is going to offer some respite for all these residents. I feel that all the residents will benefit from this program. And now I would invite our President USI, Dr. Mallikarjun, to give his opening remarks. Over to you, Dr. Mallikarjun.
Thank you, Keshav. I think more customary remarks over here. I know that we had fantastic faculty today. They do their best to teach the postgraduates and the other junior urologists and what can be done and how it can be, training can happen. I understand that once upon a time, the volume was quite good and the people were getting exposed to good volumes. But nowadays, I think the volume is not going to be, volume is going to be the biggest problem for any junior urologist. Seeing two cases and doing the next case is going to be a difficult, it's not going to be easy at all. I think these programs should help them in future, and possibly I would say that in the next few programs will dwell into the deeper parts of deeper ways of training them in a different format. Possibly we have been tuned to one particular format all these days, and possibly we look into in a different ways in a 3D imagination or some sort of a reconstructive format. Thank you very much for this this thing, and all the best to this program.
Thank you, Dr. Mallikarjun. We have 2 days of this program. Today we have 2 modules. One of the modules would be moderated by Dr. Ashish Patil.
Keshav, Rajiv has joined.
I think Rajiv has not joined.
He has joined. He's just joined.
Okay. Dr. Rajiv is there. Chairman of the ISU, for your opening remarks. I didn't see your...
Okay. I think the light is darker on my area. Anyway, our president, Dr. Mallikarjun Keshav, and my co-chair, Dr. Arun Chawla. Today, it is the great time. In 2021, we are able to do this third UROMET, of course, because of the COVID pandemic, it is the virtual one. But I'll tell you that we were able to do in March, February, March, 2 physical UROMETs, which was the requirement for the last year. Why UROMET is important? That is in the one of the lecture I am going to give for 10 minutes. And this is the part of the vision document. This is the part of the competency-based training, and this is the part of the new norms of education, and it is must simulation based education which is integrated, and we are the now global leaders, one of the global leaders in simulation based training. We have imbibed various skills from other forerunners in this program, and we are doing in many fields better. Our innovations, where Dr. Ashish is also in our faculty today, and our innovations have reduced the cost of our modules, and also we are using more number of stations. We are a large country, and we have to train around 300 plus entrants every year. And this is our endeavor, that in this, our 4 important modules we have tried to cover with 1 hour each, approximately each day, 2 hours, and 4 modules. Otherwise, we are using 6 modules in the UROMET programs, and we are doing it. We are hopeful that in the near future we will be able to revive our physical UROMET program. but great effort has gone into this program's thinking about this program, crafting the steps, modules carefully, and Dr. Keshav and Dr. Arun has done a lot of work to make it a reality. I am very happy that this is the UROMET program, which is as good as a physical UROMET, and we will be able to do other UROMET programs also, that cadaveric and hands-on and wet lab very soon. With this, I all the good wishes, best of the luck for all the presenters and their teams, and let us start the program. Thank you, Dr. Kesh.
Oh, thank you, Professor Sood. Now I would invite Dr. Ashish Patil for the first module, which will be PCNL. Over to you, Dr. Ashish.
Thank you so much. Hope I am visible and audible. Thank you, Dr. Mallikarjun, President USI, Dr. Keshav, Honorary Secretary USI, Dr. Rajiv Sood, Chairman ISU, and Dr. Arun Chawla, Sir, Co-Chairman ISU, for giving us this opportunity to present the PCNL module. Today we have excellent speakers with us, Dr. Lokesh Patni, who is going to give us the anatomical considerations. We have Chandramohan right in the OR, who is going to show us the OR setup. We have Dr. Dilip with the armamentarium, and then myself on the simulator. Hope that we do a presentable job when we are trying to teach the students simulation when they cannot have their hands on the simulators because of the COVID situation. I would like to invite Dr. Lokesh Patni without further ado to tell us something about the anatomical considerations. Over to you, Dr. Lokesh.
Am I visible, audible, sir?
Yes, you can share your screen.
Yeah, sharing, sir. Good evening, everybody. Thank you, everybody, for giving me the opportunity to speak on the anatomical considerations in PCNL. Understanding of renal anatomy and the perirenal anatomy is critical for obtaining a safe as well as effective access. Variations in anatomy can make the access challenging even for the experienced surgeons, and it might be a hindrance for the novices. So there is a short video we see regarding the anatomy. So we can see that the kidneys are located on the either side of the vertebral column behind the ribs, the 10th, 11th and 12th ribs. The crus of the diaphragm, as you can see, is on the sides. They lie on the psoas and the quadratus lumborum muscle, and kidneys are actually on the both sides of the vertebra, and they are inclined 30 degrees to the vertical. These are the relationships with the major abdominal organs. 10th and 11th ribs, they are over the upper pole of the kidney. The major vessels are there. You can see the inferior vena cava and the aorta on sides of the both kidney. The renal vein and the renal arteries are coming from the respective aorta and the IVC. So the diaphragm lies above the superior pole. So there are chances of perforation of the diaphragm when we go to upper pole. The quadratus lumborum and the psoas lies on the posterior aspect of the kidneys, and you can see the various nerves and relationships to the kidney. So talking about the major organs, solid organs, the suprahilar region of the kidney is occupied by liver and the spleen, where they can have large dimensions in case of hepatomegaly or splenomegaly. During inspiration, liver and spleen come down, so that should be kept in mind while doing the puncture during inspiration. The risk of injury is more with a lateral puncture to the kidney. Ascending and descending colons are there on the both sides. Hepatic and splenic flexure, they lie anterior to the kidney. There is 10 colon. So we should see the movement of the colon with movement of the kidney during respiration. A CT scan is handy if you are suspecting a retrorenal colon. Nowadays, as we all are doing CTI view before the procedure, so it is a safe practice. While puncturing, the colon should move independent of the needle. USG guided puncture colon is occupying whole of the posterior aspect of the kidney, and this may be a fluoroscopy guided puncture. So the relevance of this is intra-abdominal distension post-operatively should indicate about the solid organ injuries or should alert a possibility of a bowel injury. Post-operative hypotension or bleeding through the nephrostomy tract may be because of a solid organ visceral injury. Pleura also lies behind the kidneys. Intercostal and supracostal approaches have the risk of injuring the pleura. While puncturing, we perforate the diaphragm many times, but pleura are also more chances if we go intercostal or supracostal punctures. So we have to take appropriate measures intraoperatively and postoperatively to avoid and detect the pleural punctures. The intercostal vessels, they lie on the inferior aspect of the respective rib. So we should be puncturing through the upper border of the lower rib to avoid the injuries to the intercostal nerves. Intra-renal anatomy, the renal parenchyma is divided into cortex and medulla. The cortex is the outermost part containing the glomeruli and other parts of the calyceal orientation of the upper and the upper calyces is medial and superficial, and lower calyces are lateral and deep. Most of the right kidneys are broader type kidneys where the posterior calyces are lateral, and in the left kidneys the posterior calyces are generally medial. The kidney is supplied by the main renal artery divided into segmental arteries, and the anterior segment supplies the anterior and the some of the posterior part, and the posterior branches supply the posterior aspect shown in the shaded area. So there is a broader vascular area where both the anterior and posterior circulations meet. So this is relatively an avascular area where the puncture is safe. As we can see here, the segmental arteries, they lies on the pelvis. The interlobar arteries, they crosses over the infundibulum. So we should not be puncturing medially. We should not be puncturing the infundibulum. Hence, the posterior inferior calyceal puncture are the safest for the access. So the take-home message would be diaphragm and pleura can be violated during upper pole access, so care should be taken. Colon can be lateral or even posterior to the kidney. These things should be kept in mind while preparing for a puncture. The determination of the anterior posterior orientation of the calyces is the most important aspect to decide which calyx to puncture. The safest place for percutaneous access of the collecting system is the posterior approach and directly onto the calyceal fornix. Thank you very much.
Thank you, Dr. Lokesh, for that anatomical consideration. Can I invite Dr. Chandramohan to show us the OR PCNL setup? Over to you, Chandramohan.
Yes, sir. Good evening, everyone. At the outset, I thank Urology Society of India and ISU for giving this opportunity. I will directly go to the topic. Supine PCNL and prone PCNL, two things we will show the OR. This is primarily around 20 by 20 room. Am I audible, sir? Hello?
Yes, you are audible. You are audible.
So this is approximately, if you have 20
yes, sir, you are audible.
Approximately 20 by 20 room without any pillar is there, because CM has to move all around in case required. That is the primary requisite. 20 by 20 is best, but 20 by 15 is also okay. First, before we start the case, on the right side, we will have the X-ray board. Whenever surgeon stands, he should be able to see on his front, whatever may be the case. Next, coming to the table. Table should be in the center of the operation theater so that CM can be placed that side or this side. The attendant should be anesthetist, like he is my anesthetist, he is anesthesia monitor. So anesthesia and anesthesia monitor is not at all related to the surgeon. Now coming to the primary equipment, how you set up. Primary table will be on the back side of the surgeon. Sister will be here or here on the back side, exactly back. You don't look like this. Sister will give directly like this. Coming to the lithotripter, normally we use pneumatic lithotripter that will be placed onto the surgeon's right hand. So if the surgeon wants a pneumatic lithotripter, they should be able to bring it like that. Next comes the laser. Sometimes you use pneumatic, sometimes you use the laser. This is the only part where laser fiber will come to the surgeon like this, so that nobody can travel from here to here. If you have to travel, you have to go like this only. Otherwise, the laser fiber will go. So all the equipment which are used are on the back side and right side of the surgeon. Coming to the most important point, monitor and CM. The CM operating person, for example, if it is on the supine Pcnl, it will be always on that side. Always on that side. In prone Pcnl, depending on the stone position, it can be changed. CM person should be able to see. Ideally, CM should be taken by the surgeon. CM person should be able to see and surgeon also see. That's why we have kept on the foot end side of the this thing, CM monitor. So that when he sees, I will be seeing. So that we both coordinated how much up and how much down. And coming to the first monitor, usually one monitor will be there in the theater. It will be in front of you. For example, if you are doing any surgery, you will be seeing like this, and your monitor is here, your CM is here. Vice versa also can be there, no problem. But primarily 30-degree angle, right or left, if CM and X-ray are there, it is okay. Then head aprons and all this should be kept in the side, either outside the theater or inside the theater, no problem. That should be on corner, and all ureteric catheters and everything should be at one corner. So they should not be interfering your primary surgery. Coming to the most important point, for example, we are using lithotripter here, you need a cut box here. So whenever you are making the OR setup, keep all around, if you see here, all around small peg box are there, all around. So that you can use any electrical point. They should be high wattage, 10 watts power should be there. Because 100 watts laser can be used, 60 watts laser, 30 watts laser. Most of the times, highest energy is used by the laser. Least energy is used by the monitor. Only 2 kV, 3 kV. So you should go according. If you have all around, it is easy. This is the primary setup. Now, if you I have spent 5 minutes, another 5 minutes in relation to the surgery, how it will go. For example, if it is supine Pcnl, you should keep these bolsters are all ready somewhere so that they will give it. So all the things you have to keep ready. I am not going into the instruments part because next person is talking. Keep a minimum on the table. One more table you keep on the back side so that they will give, so that they need not be cleaned. Unnecessarily sterile or chemical sterilization is wasted. So this table should be minimum, and backside one more table should be less, so that you can give multiple catheters like that. Now coming to the position, see, always a tall person, table is usually 7 feet will be there. Once the anesthesia is intubated, you have to bring it down. You should ensure that this part is not under this job. Otherwise, you will not be seen. Once you go down, go down. Now, I am not going into the positions, puncture. I am just showing how the equipment will be useful. See, if this leg is straight, if this leg is, for example, I will do catheterization. Sister will view from this. I will do ureteroscopy on the left side. I will pass the ureteric catheter. Then I will come like this. Now, laser is not used. Now, when I am puncturing, I have positioned the patient on that side. Anesthetist will keep this hand supported. Now, here I am positioning. So, automatically should be in the perpendicular mode. So, come a little bit this side, he will give some. Then I will puncture. I will see this CM. He will also be seeing. After that, I will take one instrument. I will be keeping here like this. One instrument. Once the dilatation is done, once the CM is there, it can go back CM, so that monitor is not moved. Whenever you want to come, he can come. Ideally, you should be able to hold and tilt like this. Once you are inside, CM is not used usually in Pcnl. So you will see the monitor. Rarely when completion nephrostogram, you can see that side. That is all. Nothing abnormal. If it is prone, then you turn back completely. You have put ureteric catheter. You are putting the prone. And at the same time, very important is upper rib part should be below this all this. So they come down. If at all is tall person like this person, you are doing some support here. If it is too much hanging outside, you are to keep one more table here, so that these things are not affected. Now coming to the prone, if the patient's stone is on the left side, the C-arm should be on the right side. If it is on the right side, C-arm should come all around. All this equipment should go that side. That planning should be there in the beginning only. So to summarize, otherwise I'm not going to any surgical details or things. To summarize, whenever you come from the OT room, this is the OT room. You open the door and come. You see here first what is the case. It should be on the right side. First assess and then go to the scrub nurse here. The table here, scrub nurse will give this, and then you plan puncture. The C-arm will come opposite of you. On the right side, C-arm screen. On the left side, normal screen. And then on the second side, laser. On the right hand side, the without respiration. And the oxygen cylinder will be connected to that so that it will never come into picture. And plug boxes should be there all around. This monitor is extra because if you are doing ECIRS, for example, I am doing Pcnl, some surgeon wants to operate something, he can see there by the side of the anesthesia. This is the last part I want to tell. By chance, you need two surgeons, two monitors, ECIRS. On the front side of the surgeon, supine Pcnl or surgeon that side, and head and side will be the monitor. That monitor can be seen. So with this, I conclude my talk. This is the position, and all the IV fluids, all the exchange of the material should be on the corner. That should not be seen. That should not come in your weight trolleys. And all anesthesia should be at the back corner. No interference with the oxygen, nitrous oxide, or whatever it may be. So they are separate completely. So this part only should be movable. Only place which is closed is this laser fiber, because otherwise it will break. One should be careful. Whenever he wants to give, he will give. Whenever you want to keep, he will keep it there. So this is the OR arrangement. If you have one more, if you are it is exactly square, you can keep one more arrangement of the oxygen like that, so that if that doesn't function, everything can be shifted here. A square type 20 by 15 to 20 by 20 is a perfect OR. Thank you very much for giving the opportunity. With this, I conclude my talk.
Thank you so much, Dr. Chandramohan, for the excellent OR setup. Can I invite Dr. Dilip Mishra to tell us something about the armamentarium on PCNL? Dr. Dilip.
Thank you, Ashish Patel sir and USI for giving me this opportunity. I'll share my screen. Am I audible, sir?
Yes, very much. You are visible also.
Okay, sir. So I will start my talk straight away. The topic which I have been allotted is armamentarium in PCNL. So I would be discussing all these things which are listed here, starting from my initial puncture needle guide wires, Alkan stroker, cannula, dilator sets, access sheets, nephroscopes, and maybe if possible lithotripsine accessories in my talk, because quite a lot of is there to discuss, but I will try to cover up as much as possible. So starting with PCNL procedure is divided into these headings, where initially you do cystoscopy, RGP, and ureteric catheter initiation, followed by you do a puncture of the desired calyx, then you park a guide wire, then you plan for a safety guide wire if somebody a novice is doing a PCNL, then you do a tract dilatation, then you put an access sheet inside, then you do nephroscopy, followed by stone fragmentation and retrieval, and then the exit strategy. So I'll go step by step. So for initial ureteric catheterization, you do a cystoscopy. We use this kind of ureteric catheters which are available in multiple sizes and diameters. And most commonly, a 5 French ureteric catheter is used, which is made up of PTFE, and it serves the purpose of injecting contrast into the PCS to visualize for doing a C-arm guided puncture. Sometimes people also use a balloon-tipped catheter, ureteric catheter, to stop contrast and stone fragments from escaping from the PCS during PCNL. Following this, we generally take whatever position we want, and then we go for the puncture. Initial puncture needle, which is supplied by Coke and many other vendors. Generally, most commonly it is an 18 gauge needle, which is available in two sizes of 15 centimeter and 20 centimeter, and it takes up guide wires of 0.038 and 0.035. Even smaller guide wires can be taken. And this needle, which is shown here, is an eco-tip needle, which has got a disposable two-part. And the advantage of this needle is that it is very much visible if you're doing an ultrasound guided puncture, because it gives a nice reflection of the ultrasound waves. Now, this is a three-part needle which was used initially. Still, some people use it, but not many. And the advantage of this 3-part needle is that the inner needle, which is 22 gauge, is smaller and it is longer. So if you are doing a puncture with the multiple times you are trying to puncture, you're not able to puncture it, then this needle will cause less injury to the renal parenchyma. And once you are inside, you can remove the slit and see if you are inside. And once you're inside, you can advance the third outermost needle inside the pelvic ulcer system. So going ahead with guide wires, which we most commonly use in PCNL is Terumo guide wire. I think 90% people use Terumo guide wire, which is called a hydrophilic coating. They are further divided according to their size, tip design, surface coating, and shaft rigidity. I will not go much into the details. The guide wires which we most commonly use is 0.035 and 0.038 while doing an initial puncture. And here is the list of scopes through which these guide wires can be used. Generally, guide wires are 145 to 180 centimeter in length. The tip design is very much important because the tip needs to be floppy and it needs to be flexible. Either it could be straight, angled, or J-tipped according to the preference of the surgeon. And it needs to be floppy because once you're inserting inside the pelvic ulcer system, it should not injure the in the mucosa of the pelvic ulcer system. And sometimes you can use both ends floppy tip for backloading also. Then surface coating, whenever we use the surface coating could be hydrophilic, which we generally use in Terumo guide wires, and it could be PTFE coating, in which gives very smooth advancement for these guide wires. We generally use hydrophilic guide wire, which is called Terumo guide wire. And again, shaft rigidity is also important. I will not go into its detail. Now, this is the guide wire which I was talking about, Terumo guide wire, which is available in most of the sizes, and it is 180 centimeter in length. It is the most commonly used guide wire for making Pcnl punctures and parking into the system because it is got a hydrophilic coating, which gives little silkiness to the guide wire, but then it passes on very easily inside the system and it can be parked inside the upper ureter. There is another guide wire which has been used off and on by some people, which is called Schuller's guide wire. It's got a steel J-shaped tip, a floppy part, and a rigid shaft, which helps in maintaining the angle and the direction of the initial puncture. So coming on to the safety guide wire. So when we are using a safety guide wire, it's the second guide wire which is used as a safety guide wire. It can be introduced by double lumen catheter or a coaxial system. Double lumen catheter is after the initial guide wire, you can put in a double lumen catheter and then you can pass the second guide wire. The coaxial system is given by Alken, Stroker, and Canula. This is the coaxial system in which you can puncture, after the initial guide wire, you can pass on this Alken's cannula, and then a second guide wire could be placed. And one guide wire is segregated for doing dilatation. The other guide wire is kept outside the sheath as a safety guide wire. Coming into the dilatation methods, we have got 4 dilatation methods: Teflon coated semi-rigid dilators, Alken metallic telescopic dilators, balloon dilators, or a single step dilators. Now, these are divided as per the flowchart shown here. Coming on to the dilators, Amplar dilators, which is most commonly supplied. This is the set of dilators which is supplied by Cook, which is most commonly used. Here we have got a black Cobra guide wire, which is passed onto the initial guide wire. It supports the guide wire, and then you can serially dilate the system starting from the first dilator going on to the maximum, whichever is your preferable diameter for dilatation. So this one by one, you pass one dilator and come out, and then this again can be used as a single step dilator. If you want to dilate to 24 French, you can straight away use the 24 French dilator over the Cobra guide wire. Then comes the Alken's telescopic metal dilators. This was initially popularized by Dr. Peter Alken, and here you can see there is got a long central rod with the oval tip, and there is a set of 8 dilators which are moving in a step of 3. So 8 French central rod is there, followed by 9, 12, like that. It will go on to 30 French, and you can dilate it up to the level which you want the dilatation to be. And then after the last dilator, you can pass on the Amplar sheet, and the whole system comes out smoothly through the Amplar sheet. So this is the Alken's telescopic metal dilators. These are some finer points of these telescopic dilators. The knob which holds all the dilators in place, the tapered ending of the
Yeah, continue.
Next set of dilators is called the single step dilator or screw dilator. Here you can see this is a single step dilator which has got a screw tip, and this works very well because it saves a lot of time, and this thing you can pass on after putting in the guide where you can pass on the dilator straight away with the screwing movement, and over this the access sheath whichever you're using. This is mainly used in mini Pcnl. The access sheet can be placed directly over this Amplar. It saves a lot of time, and there is no repetitive in and out movements in this type of dilators. And the last one is the balloon dilator, which is less commonly used in India. It is available only in large sizes of 24 French or 30 French. And the peculiarity with this is that this is again a single step dilator. After passing the guide wire, you can put in this balloon, but Amplar sheet should always be preloaded before passing the balloon dilator, because once you pass in the balloon, you cannot remove it and pass in Amplar sheet. So once the balloon is inflated to a certain pressure, it creates a tract from the skin up to the inside the pelvic system, and you can pass on the Amplar sheet over this balloon dilator. So that's all about the dilator. There are certain problems with these dilator systems. Serial dilators requires repeated passes to create a tract. Each passage produces a drag force that shears the vessels and causes tract bleeding. So there could be more bleeding with serial dilators. And multiple passes increase the risk of collecting system perforation in these cases. Whereas this problem is not there with single step dilators. Balloon dilators are expensive and they are for single use only. And single step screw dilators are available in the market, which are for single use only. So coming on to the access sheets, this is the most common access sheet which we use. It's called the Amplar sheet, which is supplied by many vendors. It is made up of radiopaque PTFE and it is standard. It is 16 centimeter in length. More longer Amplar sheets are available, which can be used for obese patients. All the sizes are available, and the end which goes inside the kidney is beveled, so it allows you to make it a screwing movement and go inside the pelvic system if suppose you are a little bit outside the system. Then we have got Shah sheet, which has been devised by Dr. Kaushik Shah. It has got a suction attachment, and we can control the suction also, and it works very well in mini Pcnl with the suction attachment. All the stone fragments can be removed. Then we have got a clear Petra sheet also. It also is similar to the Shah sheet, but it has the suction attachment at an angle to it, and it also works very well. Coming on to the nephroscopes, we can have nephroscopes which are large size, which are more than 20 French. These are the two nephroscopes which are shown, which one is Wolf and one is Stowe's nephroscope. The nephroscope shaft is 25 centimeter and diameter is 26 French. These are the large nephroscopes which are very seldom used nowadays, but they've got a very large working channel, as you can see in this picture, and you can remove large bulk of stones with these nephroscopes. This is another nephroscope supplied by Wolf, which is called Reston model. It is a very versatile nephroscope of 20 French, and it can be used in place of those larger nephroscopes with a larger sheath. Now we come to mini nephroscopes. This is the most commonly used mini nephroscope supplied by Stowe's, and the diameter of the mini nephroscope should be less than 20 French, but this one is 12 French diameter, and it's a very sturdy nephroscope. It can be used for mini Pcnl in settings. These are the table which is showing multiple manufacturers with their nephroscopes, and we can also use. Then coming on to stone fragmentation and retrieval, there are just two more slides. So for stone fragmentation, we can use all these ultrasonic, pneumatic, laser, and electrohydraulic. I will not go into the details because there is not much time. These are the ways how we, the lithotripters, various lithotripters work. Coming into the retrieval methods, we can do forceps extraction or we can do suction. And we have also got retrieval methods in which the vacuum cleaner effect works in mini Pcnl. These are the forceps which we use for stone retrieval. Then these are the suction devices. That's all from me. Thank you very much. Over to you, Patil sir.
Thank you, Dr. Dilip. We'll go and share my screen. Yeah, hope I'm audible and visible. So I'm going to talk about the puncture techniques for Pcnl. Most of the illustrations and principles may be based on our Pcnl experience and simulation principles. That is a disclaimer. What is most important, I think, when you ask any beginner like the PG residents, it would be a successful calyceal approach, which they have observed also and they feel also is a little tricky step of PCNL. Well, one needs to remember that during self, one always aims at dodging the viscous, that is the liver, spleen, pleura, and bowel, and all the unseen vessels like the subcostal and the various renal vessels. So whenever I tell about a PCNL puncture, there are two entry points basically for the needle when you go through the abdominal wall. One is the skin entry window, that is the area from where you can put the skin, needle into the skin, and the renal entry point, that is the point in which you want your needle tip to enter the kidney. So skin entry window is very important. There are no standard guidelines as to what should be your skin puncture area. It needs to be individualized according to the patient. And at the end of the day, you need a short, straight, and coaxial access to the desired calyx with the patient prone or supine. Renal entry point has to be through the appropriate calyx, and one wants to always avoid the renal vessels. So if we look at the posterior sort of anatomy of the body, we definitely do not want to have our puncture in the midline, because most of the vertebral column as well as the paraspinal structures are in the midline. We do not want to be very high because we want to avoid the pleura, liver, and spleen. Not too much lower and lateral because the bowel would be there. So what we are basically left with is these sort of triangular areas, which are the golden spot areas from which we would like to aim our puncture. Now, which calyx? Well, always for a beginner, I would say that it has to be the lower posterior, then the middle posterior, and then the upper lateral by preference. Intravascular anatomy, I divide it mostly into the medial part, which is a Barberion's area, because these are the very large vessels, and to hit those vessels, you really need to be very rude with the kidney. What usually during the puncture we feel or we see being punctured is the surgeon's area and the smaller vessels, that is the interlobar vessels and the others. Brodal's avascular plane, Dr. Lokesh already has touched upon. It is at the junction of the posterior 1/3 and the anterior 2/3 of the circumference, if you see it in the transverse section. And that is one of the reasons why we want our puncture to be from the lateral side. Now, if we look, why the posterior calyx? So if this is the posterior calyx in a Brodal's kidney, and this is the Hodgson kidney, the posterior calyx, this is the posterior side, this is the anterior side, obviously medial and lateral. So why do we want to puncture these posterior calyces, either in the Brodal's and the Hodgson's? So if we have a posterior calycial approach, usually when we put in the scope, we need to remember that when our scope enters the calyx and goes to the pelvis, it is not the scope that is bending, but it is actually the kidney which we are flexing over the scope. We are sort of intercepting that kidney over the scope so that we can reach the pelvis. Hence, the number of angulations that we get are going to create torque on the renal parenchyma, cause tears and bleeding. Hence, if you see the posterior calycial approach, we would have this kind of angulation. If you try to do the anterior calycial approach, from the posterior side, you would enter the anterior calyx and then go upwards towards the infundibulum and then towards the pelvis. So more turns, more torques, and more tearing, more bleeding. Hence, always the posterior calyx. So this is the posterior calyx, lateral view. If we want to go to the pelvis and then to the ureter, if I do the same through the anterior calyx, I'll have more curves during the puncture and maneuver. Now, this is the point where we want to be in. We should be at the cup of the calyx with the needle. We should have the shortest and the straightest route from the skin. So we want our needle tip to be here. Now, to reach the same point, we definitely do not want to come from the lateral side and damage a vessel, or we do not want to come from the other medulla damaging a couple of interlobar arteries, because they would definitely cause some amount of bleeding. You do not want an infundibular puncture for obvious reasons, as you can see in the diagram. Your needle puncture cannot be short. It has to be the right length. So even though your direction may be correct, your depth has to be accurate also. Now, even if your angle is correct, your depth is accurate, there's no point in overshooting, because you may damage some vessel which is beyond the desired point. So how do you puncture? There are various ways in which puncture has been described, but the most important thing for a beginner, I would say, is learning the Bullseye technique and the Triangulation technique using at least the biplanar axis of the C-arm. All techniques try to mathematize and make puncture objective. What as students you need to develop is developing a three-dimensional understanding as to where your calyx is, where your target is, and how would you approach the calyx with your needle. Now let us go to the Bullseye technique first. I would request all of you to rather try to memorize this, the steps that I'm about to tell you, and then you'll get a better hang when I show the simulation videos. So when you do a bullseye, basically you study the pelvic calyceal system and then move the C-arm to the 30 degrees. Now, when the C-arm is in the 30 degrees, imagine that your eyes are on the C-arm and you're watching the kidney in this direction. Then what you do is you basically have a skin mark over the calyx. So you're watching this calyx through this mark into the C-arm, and then this would be your skin point. So in bullseye, the 30-degree C-arm position would tell you where you have to stab the skin. Once you have a stab, you'll put the needle through the parietes. You adjust the needle so that the needle is seen as a point. So the needle basically is lying on the axis between the C-arm, the skin puncture, and your calyceal entry point. Hence, the needle would look like a single point or like a bullseye. But when you look at the needle from this 30 degrees, you will not be able to access the depth. Hence, to access the depth, you have to move the C-arm to another degree, that is basically to 0 degrees, and then you will be able to gauge the depth of the needle, and that would decide how deep to go. It is always better to calculate your movements before the puncture and do the exact puncture, rather than you stick your needle inside the kidney or inside the patient and then try to figure out whether you have punctured the calyx or not. So these are the steps which I'm not going to wait on, because these are all available on our USI simulation, the UROMET website also, and also the QR codes are definitely there in the video that is upcoming. A brief couple of points on triangulation technique. So how do we do the triangulation technique? It is a little more intricate than the bullseye technique, because here we are adjusting the needle in two directions using two angles of the C-arm, that is 0 degree and 30 degrees. So basically, let's go through the steps. So C-arm in 0 degrees, we have already identified the posterior calyx here. So draw an imaginary line from the calyx going upwards into the sky. Keep this point in your mind and just memorize a point here. That is not used for puncture, but for later reference. Now imagine a plane which is parallel to the body. So this is the foot end of the patient, this is the head end of the patient, and we have a parallel to the ground kind of a plane here, which is the horizontal plane. You put your needle over the point in over the calyx in 0 degrees, but definitely you are not going to puncture the patient here, because this is too midline and we do not want the midline structures to be punctured. Hence, you would always first you adjust the direction of the needle so that the tip of the needle is pointing towards the calyx when you watch it through the C-arm. But because you do not want to puncture here, you are going to move the needle backwards. Now, there is no fixed formula of how back you want to go, but you want to remain posterior to the posterior axillary line. You do not want to be very midline. There is no fixed formula like 1 finger, 2 finger, 4 finger, because the surgeons' fingers are different. Some surgeons would have thin fingers, some would have fat fingers. So you have to individualize this. Here you would decide where to puncture the patient, not the C-arm. So when you go to the 30 degrees, then you are going to have another plane here. Because if you puncture in this direction, for example, your needle will go here superficial, but your calyx is here. So you need to have a sort of inclination to reach the calyx. And that is where this vertical plane comes into picture. So you need to move your needle into the vertical plane. You remember that this vertical plane movement is only visible in 30 degrees. while the horizontal plane movement is visible in the 0 degrees, which we will definitely understand when we go to the simulation videos. So your needle basically has to pass along the hypotenuse of this so-called triangle. Remember the vertical line that I was talking about, going from the calyx to the sky? This is the vertical line. You draw a line imaginary along the horizontal plane. This makes a right angle. This is the right angle triangle that is formed, which is usually referred to in various studies. And you want your needle to pass along the hypotenuse of this right angle to the calyx. And that is why maybe it's called the triangulation technique, because you have a sort of right angle triangle here. And you're going to pass your needle. So these are the steps, which again, I'm going to skip here for obvious reasons. I would like to stop sharing my screen here and go to the video screen, which is a video present on the YouTube. So hope this is visible.
Yeah, nice.
Fluoroless simulator, I would request you to scan the QR code which is seen on the side and download the exact steps of Bullseye and Triangulation Technique. Hello friends, today I'm going to demonstrate the Bullseye technique using the puncture logic bench. Imagine that this is the calyx, and you want to use the needle given on the logic bench to puncture. So the task is, using the bullseye technique, we touch the tip of the needle to the target. So how do you do it? In bullseye technique, after identifying the posterior calyx, you shift the C-arm from 0 degrees to 30 degrees and mark a skin point over the calyx. You take a stab incision there, pass the needle through the parietes, and then try to get the hub of the needle, the point of skin entry, and the calyx all in the same line, so that the needle looks like a bull's eye. Let us try to do it. So now if we see in the 30-degree camera, the hub, the point of skin entry, and the calyx are all in the same line. But when I try to progress the needle towards the calyx, I cannot see how deep I'm supposed to go. That is the time I would shift to 0 degrees in order to look at the depth of penetration. So now let us look at the 0-degree camera and try to figure out how deep we are supposed to go. Keeping the needle direction stable is very important when you shift from 30 degrees to 0 degrees. Maintaining that direction will help you achieve a successful bullseye. Using the 0-degree, one gradually progresses towards the calyx, noting the depth of penetration.
We'll do some exercises on the Fluoroless simulator.
So let us see the bullseye technique on the Fluoroless simulator. We inspect the pelvic calyceal system in 0-degree fluoroscopy. Keeping the fluoro on, we rotate to 30 degrees to identify the posterior calyx. We select the desired posterior calyx and make a puncture skin deep. Then we insert the initial puncture needle and make a bullseye. We go back to 0 degrees and look for the appropriate depth of the needle and then hit the calyx, which is indicated by an alarm. I'm going to demonstrate the triangulation technique using the logic bench simulator. The logic bench simulator is basically a needle mounted on an apparatus which allows the needle to be moved in the horizontal and the vertical directions. So this is the horizontal movement of the needle which is allowed by the apparatus, and this is the vertical movement of the needle that is allowed on the simulator. We have a target calyx here. So the first task is to make the tip of the needle touch the calyx. For the learning purpose, we have two cameras. One is at 0 degrees and one is at approximately 30 degrees, which represent the 0 degrees and the 30 degrees of the C-arm. So if the task of touching the tip of the needle to the calyx is given, what would one do? First, in 0 degrees, one would try to get the tip of the needle just over the calyx. But then one realizes that the tip of the needle, though coincides with the calyx in 0 degrees, it has still not touched the calyx. So we need to give the needle an angle of inclination and then pass the needle deep into the body. So even after the horizontal plane adjustment, we will have to do a vertical plane adjustment so that the needle goes deep and touches the calyx or the target. It is important to note here that if we move the needle in the horizontal axis, it is well appreciated in the 0 degree camera position. And when I move the needle vertically, it is hardly appreciated by the 0 degree camera. That essentially brings us to the conclusion that the horizontal plane movement has to be done under 0 degree position of the C-arm, and the vertical plane movement has to be done under a non-0 degree position of the C-arm, or conventionally in a 30 degree position of the C-arm. So where is this vertical plane? If we try to represent it on the logic bench, it is somewhat like this. So now this is the plane, which is the vertical plane in which we are going to move the needle so that it gets an angle of inclination. As you can see, this plane is hardly seen in the 0 degree position of the camera, but it is very well seen in the 30 degree position of the camera. So now let us do the part 2 of the task, in which we want to give an angle of inclination to the needle so that the tip of the needle would touch the calyx. We move the needle in the vertical plane, which is well appreciated by the 30 degree position of the C-arm or the camera. We adjust it such that the needle is pointing towards the calyx. Now if you see in both 0 and 30 degrees, the needle is pointing towards the calyx. One can shuttle between 0 and 30 degrees and gradually progress the needle towards the calyx till the time it touches the calyx. Now, if you draw an imaginary line from the calyx going upwards, and also you look at the point of entry of the needle in the skin, and try to join these 2 points along with the calyx, this is what you get. We thus form a right angle triangle with the right angle line at the skin surface. And the needle is actually following the hypotenuse of this right angle. And hence maybe it is called the triangulation technique. Let us see at the triangulation technique on the Fluoroless simulator. We study the pelvic calyceal system in 0 degrees using the fluoroscopy. Place the needle tip on the calyx to be punctured. Then we are going to withdraw the needle because we do not want to puncture in the midline. Then we puncture till the parietes. Study the vertical plane movement of the needle. It is seen on the surface, but it is not appreciated on the 0 degree of the C-arm. Now study the horizontal plane movement of the needle. It is well seen in the 0 degree of the C-arm. Now in 0 degrees, we point the needle towards the calyx by doing the horizontal plane adjustment. When we shift the C-arm to 30 degrees, we realize that the needle is no longer pointing towards the calyx. And then we would do a vertical plane adjustment so that the needle is pointing towards the calyx. Gradually shuttle between 0 and 30 degrees, progress the needle till it hits the calyx.
So after that video, I would like to So this video is on the YouTube for those to watch. A couple of slides on troubleshooting for the punctures. Hope I'm audible again. So for the beginners, it is very important to know that you should not always, you should place the open end at the right depth. You should not put it too inside, because then visualization of the pelvic calyceal system is going to be a problem. You need to identify the calyx. This is the upper group, this is the middle group on the fluoroscopy, and this is the lower group. These are actual patient photographs. How do we identify the posterior calyx? Well, there are various ways in which people do it. Either you can put in contrast slowly and then see which calyx fills first. You can use air pylography, in which the posterior calyx will fill first. You can use a mix of contrast with air. So contrast will appear black. And then when you put in air, you would see the air bubble float to the posterior calyx. And then you can move the C-arm from 0 to 30 degrees and figure out how the calyx moves. So I'm just a small video here. We have this pelvic calyceal system after we have put in contrast, and I'm trying to puncture this calyx. So here we see one big calyx here, which obviously looks the posterior calyx. And then we have this smaller calyx, which I thought was the anterior calyx. Then we moved the C-arm from 0 to 30 degrees. And if you see the video, if you can observe, what happens is this bigger thing is actually moving a little lateral, and those darker things are moving a little medial. So what had actually happened was the bigger one is obviously anterior and the blacker one is posterior. So this is a small video of how they look when you actually turn the C-arm from 0 to 30 degrees. Next time you boys go to the theater, I think you should try this out. It actually works quite well. How to hold the needle? It's very important that you stabilize one hand against the patient. May you be a left-hander or a right-hander. You stabilize your finger against the patient, because that will help you stabilize the needle. Because when you're looking at the C-arm, actually there's a lot of sway that happens and you may get disoriented. Never put your hand under the C-arm. This is a bad position of the hand wherein you're fluoroscoping your own hands. So your point of entry has to be bang center of the calyx. Free saline coming out of the patient is one positive sign that you have reached the calyx. If the wire enters easily into the system and down the ureter, most probably you are in the posterior calyx. And if the wire takes the shape of the pelvic calyceal system, again, your puncture is correct. So these are few signs which, as beginners, you can look for when you're looking for a successful puncture. This definitely is an infundibular puncture here, because the calyx is here, and the needle is entering here. This I call a wrong needle handling technique, because most of the hand of the surgeon, as you see, is getting exposed to radiation. Is this wire correctly placed? So the wire is going inside, taking a nice turn here, but you can see here it is coming out, here it is going out. This wire is not in the system. You put your needle in, you aspirate, and the first couple of drops are red. I would always withdraw that needle and repuncture. So it's good to have the wire in the pelvic calyceal system. That is good. A better would be that you enter through one calyx, you have the wire parked in the other calyces, and the best one would be you have the wire going down the ureter right up to the bladder. With these few points, I would like to thank you all for a patient listening. And if we have time, and if Chawla sir agrees, we'll have some couple of questions.
Ashish, you can just have a look at the chat box. So there's no questions. Ashish, can I ask one or two questions for the sake of residents?
Yes, sir.
Ashish?
Yes, I can hear you.
Ashish, I want this question to you or the Dilip. Anybody can answer. The difference between the 2-piece or 3-piece initial puncture needle.
I think, Dilip, can you take this one? its instruments. Can you unmute yourself?
You're muted.
So the two puncture needle, it's just got a outer this thing needle and inner stellate. So once you puncture with a two puncture needle, you just have two things. If you're inside the system, you remove the inner stellate and it comes out. Now sometimes some people are fond of puncturing in a freehand puncture, doing a freehand puncture. In those cases, you're doing puncture in a 0 degree position and you're puncturing the calyx. Sometimes when you, in those cases, if you use a three-part needle, the three-part needle consists of two inner needles, in which those two inner needles are longer in size, and that is 22 gauge needle. So, and the outermost needle is shorter and it is 18 gauge. So if you are making multiple attempts to puncture the pelvic calcium system, you are causing more trauma to the renal parenchyma. So if you are using a smaller 22 gauge needle, the trauma is less. And once you enter and you remove the stellate and if we see that the fluid is coming out, then you can advance the outermost needle to the position and then you can advance your guide wire. That's the basic difference which is comes in for two-part and three-part needle, sir.
Yeah. Why I asked is because it is usually kept in the operative session and it's a very common question for the examiner. And question to Chandramohan. Chandramohan, we were seeing your nice demonstration of OR setup. I just want to know, how do you manage the clutter of wires on the floor when you have 6 or 7 systems around you? How do you manage that?
Sir, that's a good question, sir. Generally, it happens irrespective of whatever you do, some amount of soiling and wires coming. If you have the plug boxes and if you keep as less folded, or else if you extra is there, if you wrap it and put with one tie, then mesh and the legs coming, these wires coming in the way can be avoided. Otherwise, in urology, it is inevitable that 3 to 4 wires will be there on the floor. But in advanced OR theaters, these are all comes from the roof. Maybe in hospitals like advanced medical colleges, corporate setups, there is a hanging. All OR systems have changed now. Nothing comes from floor, but still the pneumatic lithotripter one, laser one, they all will come. So it is better to have a hanging type of electrical supply as well as the other things, so that on the floor you will not have clash.
I would like to add to this, Dr. Chawla here, that other option which we use in our ORs is we have armored cables which have been laid on the floor. And these waterproof armored cables come up below the operation table and below the Boyle's apparatus. So all our electrical connections which are near the operating table can be got from under the table itself. So we don't have wires hanging at the periphery of the OR.
Yes, sir.
Yeah, I think we have a question here from the audience. If we have punctured and while dilating somehow we lose the system access, do we have to puncture again or is there some way out? Well, maybe I can take this question. If we have punctured already and you do not have the wire in place and you have not dilated, so the puncture along with the wire has slipped out of the kidney, you have no other way but to re-puncture. But maybe a couple of things that I follow here is, once you have punctured the pelvic calyceal system, do not try to put in more contrast, because then you will have contrast all outside the kidney and then it would mess up the thing. So whatever contrast you have in the PCS already, you use that along with the memory pictures which you take in 0 degree and 30 degree of the C-arm during the first puncture. Both of these, along with your bony landmarks, would guide you back to the kidney if you spend some time, maybe a couple of attempts, but you might get it. If you don't, then you should shift to an ultrasound if you have the facility in the OR, because then that would make puncture easy in such situations. Contrast extravasation. The next question is contrast extravasation around the kidney and we don't have access into the system. Well, you don't allow contrast to extravasate or try to minimize in the first instance by not pushing in more contrast or saline once you have a false puncture or a slipped out puncture, and or else you have to use the ultrasound. If you don't have an ultrasound, then you have to come back maybe some other day and try puncturing. Experts can add into these points, please.
If you
I
have,
think, Ashish, you can take another question. Following question from Dr. Manzoor. If extraction occurs and puncture is not done, picture becomes blurred, what to do? And then you can invite the other experts also.
Yes. So, Chandra Mohan, let us ask you, if the extravasation occurs and the puncture is not done, picture becomes blurred, what shall we do?
Choose another puncture with little amount of the dense contrast gently injected by the senior. So that time you cannot do another mistake, because around the Gerota, once the thick contrast come in the first go, then entire thing gets spoiled. If the stone is at the periphery, you are lucky, you can do stone guided puncture. But preferably inject around 2 to 3 ml of thick contrast and aim more meticulously through the other
No, Chandra Mohan, what he has to say is the picture has already become blurred. Now what to do?
If you are not confident, postpone the surgery, put the stent and come out. Better not to do anything blind in PCNL. Unless ultrasound is there, if you are very good in ultrasound, puncture, if the hydronephrosis is there, it's
okay,
not there, it is not safe to do puncture.
He has come up with another option. If we have to do a second puncture, can we do it in some other calyx and try to get the stone out?
Yes, sir, if it is well delineated.
Yes,
and if
so
it can give access to the stone.
Yes, that is the most important thing, I feel, that if the
Otherwise
access,
useless.
yes, so the other calyx should allow access to the stone and the other calyx should be visible and puncturable.
Yes, sir.
If you want to do a contrast guided puncture.
Yes, sir.
Dilip, any additional points?
sometimes a little amount of air can be injected and you can get an air pneumogram. That
Yes.
might sometimes help if you want to do a puncture when the contrast is already extravasated. But it should be very careful because air may also blur the picture actually. It should be very careful.
Yeah.
I'll add, Ashish, a little, you wait for some time, 10-15 minutes you wait, everything gets absorbed, and you can go ahead with another contrast installation. You can just set the concentration. Yeah. I think, Ashish, if it's okay, can we wind up the session?
Yes, sure, sir. Thank you so much for the opportunity.
Yeah. Thank you, Ashish.
Thank you so much.
Thank you, sir.
Thank you.
Thank you, Ashish. Thank you, all the faculty. Now we move on to the second module, and this will be moderated by Dr. Rishi and Dr. Raman Tanwar. Over to you, Dr. Rishi and Raman.
Thank you, sir. Thank you, USI and ISU, for having us here in this USI ISU program, UROMET program for the residents and young faculty. Without wasting much time, this is a TRP module, and we have good speakers on the panel along with Dr. Raman, my co-moderator. The first talk is by Dr. Rajiv Sood, who will be talking about simulation-based learning. Sir, can you please share your slides? Yeah, we can see you. So maybe you have to unmute. We can't hear you.
Can you see my slides?
Yes, sir. Yes, sir. Now you are visible and audible too.
Oh, okay. I'm sorry, I was muted. Oh, okay.
Yeah, go ahead.
So this is a great going. The first module is over, and now we come to TRP module. This is the basic procedure which all the residents are interested, and there are some improvements in our modules in USI, ISU, and we have now some innovations that we have added certain laser modules, and also we are working on other things. I'll come. What is the simulation-based learning? It is overview. It is common to all the module sections. Okay. So let us move further. Slide. Yeah. So what is simulation? It is, we know, imitation of a situation or a process. It can be for anything. It can be for the lab procedure also. So we are doing imitating the situation. And then coming to the next is that there are learners in this process, and there are the competency which I was talking, that is knows, that is the information given by books or given by lecture, or any way with the knowledge is coming. And after that knowledge, the reasoning is there, that is know-how, and then there is a show, like you demonstrate some procedure, and it can be that how to does the perform this procedure, and for that you do the hands-on practice, and on the simulators, on the situations which have been created, and after that there is a performance. So performance is actually, this is the situation we are creating, where we are simulating the situation. Actually, I have some problem in my presentation because I have broken my keyboard. So I am trying to use the keyboard of the this computer screen, which is touch screen. Anyway, so now, as it is for the learner, it is for the instructor also, and right from know-how, show, and actual doing it, or training, that show how, which is that our FISU faculty is doing, and after that it is being implemented, and a person is prepared, the resident is prepared for the actual performance. So there is a learning pyramid, and there can be the passive learning, and after that there can be the participatory teaching methods. So we are going for participatory teaching methods, and next is the simulation based urology education, where any educational activity that uses simulative aids or to enhance the medical educational message. And after that we go to the next stage, that is the why the simulation is needed. First we have to understand, and what happens if you are trained on the simulation, then it reduces the working hours, patient safety is there, and validation, because any simulator, when you are using, you have to validate all the procedure or the even the simulator which you are using, and there are no scope of trial and error. Practice and training in non-technical skills is easily reproducible in this simulation process. Now coming to the gross classification of the simulator. What are the simulators? Actually, first we see that these simulators are actually, there is a problem in I'm very sorry that I'm taking time. So the gross classification of the simulators which we are using are simple, mechanical, or standardized. Patient can be a simulator where you reproduce the mimicking, where the patient organ or the entire body is available as a simulator. The virtual scenario is the last type of simulator, where on the screen you are doing the procedure, but there is a problem of the tactile sensations, and also there are problems of satisfaction that you are doing something on a real thing, real replicated or 3D model. So simple, we start with the simple one. Simple simulation has many advantages. It allows the practice of the basic skills. Patient safety is there, of course, and allows practice with the minimal supervision. It is available 24 hours. You go and start getting training, but there is a lack of direct feedback and lack of patient interactivity, only useful for simple skill building. So these simulators, when are used, they provide the student with step-by-step written or image instructions initially, encourage the peer learning practice, and use with the 5-step method of teaching skills, practice to point of the automatically for simple skills. So there are, as I told you, that there can be simple, and this was the mechanical, and then there is a standardized patient. That is the third thing, or the organ system. And that is what we are using in UROMET programs. And the virtual scenario we have not used yet. And in the time to come, we may be using those virtual scenarios also. And standardized patient, these are the advanced things we have. When we take the student group to Ramaiah Hospital, there we make them work on the cadavers, as well as we make them work on the standardized patient or organ systems, and where the advantage is that the program patient reaction is there, patient safety comfort is maintained, and we learn to explain the procedure on the patients or parents, and practice draping and other physical patient preparations are taught. So there is next is the virtual. I have already explained. There are no ethical issues. That is the advantage, but very minute anatomical or histological details also we can simulate, and it can simulate a varied number of scenarios. So this is very interesting and upcoming in the simulation. Now the art of unfolding the simulation scenario. When we talk, there is a steps. This is a receipt card of simulation. Part one is the we give overview, then the simulation case is presented, and after that there is a pre-test given. After you give the pre-test, the knowledge level of the students, of the trainee, we assess, and after the procedure is over, the scenario is presented or they are introduced to that, we do the post-test and post-test questionnaire. Then that gives us this is the learning objectives we have, equipment needed we have procured, whether simple mechanized or standardized simulator or also virtual situation. Then we introduce, as I have explained, that we administer the pre-test, we give the performa, we give with the questionnaire, and after that a body of scenario, as I have told. After that, we in the conclusion and briefing is done to that group which is working on that simulator, and after that we administer the post test. So this is the various steps of assessment. And what we do, the competency checklist is there. So this is the competency based education or training which is going on. This has been recently introduced, and very soon it will be introduced in the postgraduate and postdoctoral also the curriculum also. As in the MBBS curriculum, the simulation is a competency-based education is added 2019 onward, and now we see, we tabulate what are the met objective, what are unmet things, and what is the final comment or of the instructor, of the trainer, and also the comments of the feedback on the based on the feedback of the students or the trainee. So this, after we do that, there are we should understand there are challenges. The money is required. There is a lack of funding to the institutions. We are working on that. Even National Board is working. They have a separate now section dealing with this, and lack of evidence is there, but it is acceptability is a problem in the institutions. They are not aware. Actually, to accept, you have to be there has to be perception, and also there is a limited research on these and validation. Very few people know that how to validate. That is also a matter of training. There are dependency on leadership, therefore, and also organization where you are working. So we are dependent on that, whether they are starting, how fast they are introducing these systems. And then the solutions are that you make a simulation mandatory. That is going to happen. All the residents, I'm telling that this is has been taken up by ICMR. I am the member there for that internship. Various scenarios simulation are included, and it is already integrated into the graduate curricula, and in the high flow to simulation center justifies the investment. So there are dedicated simulation centers, as we are going to Gurgaon Olympus facility, or we are going to Ramaiya for cadaveric, and we are planning to go to Hyderabad for further training on in the wet labs and so on. So the financial coverage, as in the beginning introduction, I have told that it is very important. There are huge costs, like Dr. Ashish Patil has presented, that huge cost if you buy Pcnl simulators, and how economically cheaper he has introduced in Indian, and we have adopted, USI has adopted that in our Olympus facility, where we are conducting regularly the 4 to 5 simulation programs every year. So this TURP simulators, if I'm right, it is costing just 25,000 rupees, and similarly other simulators are cheaper. And I have told you that 6 modules and 10 stations we have recently adopted, and we are working on that. So in UROMET, in ISU, Indian School of Urology, we are training. We have the other functions are there on animal-based models, which we are doing, but we were able to do only one exercise in Thailand. But in the training, the UROMET and cadaveric learning is going on, and we have this program for residents. We are having for the young faculty, and also for the consultants who want to master another art, like they are master of PCNL, but they want to learn RIRS. So we have all the programs inbuilt for our. This is the TURP. We have 2 type of simulators. We have already used Apple-based and synthetic condensed meat-based simulators. So this Dr. Raman and Rishi are going to tell you. Otherwise, Dr. Nikhil and others, many of it, even Dr. D. Ramesh have trained many of the residents. Then we have other simulators, of course. But we have added now holmium laser enucleation for some time. For 2-3 UROMET program for consultant, we added green light laser simulations also were done, and recently for last 2 programs we have added the robotic simulation. So these many simulations are not available in any of the program across the globe. And after that, these are the initiation. Those residents who are missing, very soon we hope that this kind of initiation will be there. They are given the lecture and also the demonstration, which we are trying to cover in this UROMET, virtual UROMET program. And you see that there is a training going on. There is a board on which the drawings and all are being drawn, and about the module, the initial information is given, and then there are classroom lectures and interactions with the tutorials. And after that we go for KTP and holmium laser also. Okay, so the coming to the last things, these modules are there. So many companies have their modules, or we are getting innovative modules. And also, I have already explained this. The 2019 simulation as integration of the education in India has started, and competency-based education has started. We start from knows how, show how, and after that does is at the top of the pyramid. That is the hands-on workshops on the actual patients. So these all elements are being introduced, and these level of competency we have introduced. I'll now like to conclude that we have so many ways to simulate, so many type of simulators, so many methods of performing one procedure, and we can decide not experimenting on the patient, but doing the training and experimentation on the simulators, and we know that and we get training, and we spend less time, do less harm to the patients, and this way we are promoting now also international participation. India is becoming hub, and we are promoting the best performance for the training and objectives, assessment parameters, and this debriefing conclusions, and ultimately the questionnaires we are putting to tutors, we are putting to the students, and also to the innovators, and with this, when your ambition is big, then your effort should be even bigger. I wish all of you to be introduced to the best kind of simulation training, which is going in urology, which is going to be India, leading the entire world. Thank you very much.
So thank you, sir, for the excellent talk. This talk, I would like to invite Dr. Rishi Nair to tell the residents about the basic instrumentation and how they should basically be maintaining these instruments, because both of them are very important. Understanding the instrument, to use it, and then to maintain it as well. Over to Rishi sir, please.
So am I audible?
Sir, you are audible, sir, and we can see your slides also.
Okay, thank you. So thank you, Dr. Sood, for giving us an overview of simulation. And now we move on to the TURP proper. I'll be taking you through the instruments and the basic care which are used for the instruments which are used for TURP. Slides are not okay. So why it is important to care for your instruments? Because obviously, if you know the minute details and technical nuances about your instruments, you can obviously troubleshoot the problems that may arise because of the instruments during the surgery. And as a result of which, you can also avoid complications which may occur because of that. And if you take a proper care of your instruments, the life of the instruments is better, and therefore in the long run, it also reduces the overall cost to the surgeon. So if you go back to the history, the instruments of TURP started developing 2 centuries back with the initial Bosini device for the distal urethra, and then the actual first cystoscope for the posterior urethra was devised by the Dr. Max Nidze. But it was in the last century that the major growth has occurred, and the first actual rack and pinion kind of a mechanism for resection of multiple chips of prostate was the first resectoscope was developed by Dr. McCarthy. And after that, there have been multiple developments and improvements over that. The major ones were the development of the rod length system by Dr. Harold Hopkins, and the development of this operating of the camera, that is the video laparoscopy system, demonstration by the Dr. Kamran Nizat. So if you talk about the specific only resectoscope, which is necessary for taking the prostatic chips, it includes sheath, obturator, working element, loop, and lens. But in any TURP, you would also necessarily require cystoscope, urethral dilator, or Otis urethrotome and evacuators, and sometimes even an optical urethrotome set may be required. But we will be talking more in detail about these only with just a superficial look over these instruments. So the resectoscope sheaths, most common sheath used these days is the Iglesias continuous irrigation sheath, which actually means it has two sheaths, one barrel over the another. The intermittent sheaths are also available, which is only a single barrel. There is no inner sheath in it, and there is also intermittent sheath available with the two side channels, which are draining the same common channel here, and it is there only to let the outflow of irrigant come out without actually removing the working element assembly at the back end. So these resectoscope sheets that are commonly used are 26 or 27 French. These details would vary according to the manufacturer. Minor variations may be there. The working length is most of the time 20 centimeter of a standard resectoscope sheet. The outer sheath can be identified by the presence of these multiple fenestrations that you can see at the distal end of the sheath. This continuous irrigation sheath, outer sheath also has two channels. One is for the inlet and one is for the outlet. The inner sheath that fits inside the outer sheath can be identified by the presence of this ceramic insulation. This is important not only for the insulation, but also for the reducing the brightness of the light, which may actually obscure the vision during resection. So this ceramic tip is really important for any resectoscope sheath, and if it is damaged, one should not use that sheath. So the inner sheaths are available in two forms. One is rotatable and one is non-rotatable. Rotatable means that when you rotate the inner sheath, the outer sheath does not rotate with it, and therefore it results in less shear or traction on the urethral mucosa when the outer sheath is inside. Whereas the non-rotatable fixed sheath would also move the outer sheath along with it, and therefore it would produce a curvilinear shear on the urethral mucosa, and therefore may be more traumatic in that sense. The inner sheath of the rotatable type of resectoscope is not same as the non-continuous irrigation sheath, and they are not synonymous with each other. So what happens during actual TURP is that the irrigant comes inside the inner barrel alongside the telescope, and then it goes into the bladder cavity or the prostatic fossa, and then comes back through these holes in between the two layers, in between the two sheaths, and then comes back to the proximal end to come out through this irrigant external channel and can be drained out. So what is the advantage of maintaining such a continuous irrigant flow during the surgery? One is obviously that it maintains the vision during the surgery, and because there is no need to empty the bladder continuously or multiple times during the surgery, therefore it also saves the resection time. And because the pressure inside the bladder does not increase much, therefore the fluid absorption during the surgery is also less, and therefore the complications are also less. And particularly important for TURBT is that a constant pressure inside the bladder maintains a constant, the bladder wall remains constant at all times, and this is important during TURP, not so much during TURBT. So there are SPC cannulas also available, which can also provide the continuous irrigation just in case the holes of the outer sheath get blocked. But obviously use of such a cannula would make the procedure more invasive. The operators, various types are available, but the simple operator or even the Timberlake kind of operator, these are blind and are generally not recommended for use. Best is to use a visual type of operator. The resectoscope sheets are aligned with it, and after putting in a telescope, the entire assembly is put inside the urethra and the bladder under vision, and that is considered to be the least traumatic. The working elements, we all know that there are two types, active type and the passive type. Passive type means that the working handle remains backward, which means that when the electrode is attached to this handle, it would remain inside the cavity of the resectoscope sheath in its resting state. Whereas in the active type of a working element, the electrode keeps protruding out of the resectoscope sheath in its resting phase, and it has to be all the time actively pulled back in to be so that it resides inside the resectoscope sheath without injuring the urethra. So how do we assemble the resectoscope outside? Inside the patient, we obviously put it with the visual operator inside. So here the inner sheath is being aligned with the outer sheath in a 0 to 0 alignment and then locked. The lock assembly is different with the different manufacturers and has to be learned. So then here again 0 to 0 of the working element is aligned and it is locked in position. After that the telescope is put in position and the electrical cable has to be attached at its proper point wherever it is provided by the manufacturer. The bipolar working element is same as the monopolar working element, with only difference is that you can see two sides for attachment of this bipolar cord, because both the active electrode and the negative electrode are there in the bipolar system at tip of the electrode only. So therefore there are two connections here, and this can differentiate between the monopolar and bipolar working element in the simplest manner. The loop itself is made up of tungsten carbide, and for a 26 or 27 inch resectoscope sheet, the diameter of the loop is 6 mm, which in a way means that the loop by itself will not cut deeper than 3 mm unless it is digged deeper into the tissue. And the loops are available in a thick loop or a thin loop, and even angled or straight 90-degree loops are available with benefit of each other the other. For the prostate, generally we prefer the thick loop. It uses higher current, but at the same time also produces more vaporization, and therefore resection may be faster actually with the thicker loop. Other kinds of electrodes are available, which one should know just in case if there is more bleeding. One may need to use a coagulation electrode like a roller or a cone ball, and sometimes if the prostate is very small or fibrotic, one may need to do only incision, in which case a Collins knife or a needle electrode can be used. I'll not go into the details of the dilators or otis urethrotome, but obviously these are important part of any TURP instrument trolley. Even the urethrotome may be required in many cases. And then obviously the evacuator devices are essential. Just a few words about the taking care of the instruments. After every surgery, one has to clean and dry the instruments properly. And only after their proper drying that the instruments can be stored if not being used, or to be disinfected again before they can be reused again in a surgery. The better is to always do sterilization, but sterilization may not always be feasible in a high flow surgical unit. So cleaning has to be done at the time of surgery itself. The assisting nurse has to wipe and irrigate the instruments frequently so that the clots do not dry up. And after the surgery, the same process has to be repeated. We can use enzymatic or ultrasonic cleaners also, but what is important is that we should dismantle each and every part of the resectoscope, the individual sheets, the lower locks, and each nooks and corners of these working handles. All these should be properly cleaned with the brushes or the pressurized water or air. And after only proper cleaning and drying, then only the sterilization has to be done. So if the instruments are not to be used, they should be safely put in their cabinets, which are provided by most of the manufacturers and are available otherwise also. So as I said, it is only after drying and proper cleaning that one should do sterilization. And the sterilization, if autoclaving is available, then one should use autoclave, because this is the best means of achieving high level sterilization. Otherwise, in a high flow unit, we can use a high level disinfection. So this is my last slide. I would just give you a brief overview that ultrasonic cleaning should not be used for instruments which have a fiber optics involved in them, because they create cavitation bubbles which can injure the fibers, and therefore the fiber optics can be damaged. The formaldehyde should not be used because it is toxic, and most of the time it does not provide sufficient enough sterilization for the time it is used. Autoclaving can actually be used even for lenses and the camera, and wherever feasible this should be used. Otherwise, for high flow unit, we can use a Sterat with plasma sterilization, or even Sidex or a parasitic acid solution can be used. So I would just conclude by saying that a surgeon can only be as good as his instrument. So one must be very well versed with the nuances of your instruments, and you must know how to take care of your instruments properly. Thank you very much. So with this, I will. Yeah. So with this, I will.
I'll take over now for the next part. We've made my job much easier by elaborating the instruments in such detail and also their care. So now what we're going to discuss is basically the technique of doing a TURP, and I'll be sharing. I hope you can see the slides.
Yes.
Yes. Yes.
So basically, sir, first and foremost, thank you USI and ISU for the opportunity. It is always wonderful to be a part of UROMET. And basically, the aim of this presentation is going to be to equip you all, dear residents, to perform an ideal TURP, which means that a TURP where there is minimal bleeding. So for that, we need to know the anatomy in detail to minimize the bleeding. Then it has to be a fast TURP. I would not say that we want to be deliberately fast, but we don't want to be unnecessarily slow. So again, to be fast, you have to know how to use the instrument to the best advantage and what kind of a resection technique you have to employ. Apart from that, it should be a good surgical experience for you. It should not be bothersome for you, or it should not be a reason of tension for you. So for that, you have to understand the technicalities of this surgery. And also, I will give you some suggestions in this presentation on how you can make it a good experience for you. There has to be minimal instrument damage also. It's not just that the patient should not get damaged and be benefited, but instrument also should not get damaged. But I think that most of it Dr. Rishi has already discussed. And we'll just talk while in the technique how we can probably minimize damage. And then basically it has to be an uncomplicated TURP as far as possible. And that we can do if we know the complications, we know the anatomy and the technique. So I just want to take the residents through this phase of how you become from a novice to a pro. So I would say that there are various limitations and goals based on the stages of training. And normally, first and foremost in the training, what we want to do is we want to first instruments have to become our friends. And then we have to, of course, understand the anatomy of the prostate. And eventually we have to kind of learn to make a muscle memory on how to, use the fingers and the thumb, how to basically use this shoulder joint, how to use the wrist action up and down. So all these kind of things have to come at a spinal level. So when the first to 10 cases, you would probably want to, become comfortable with the instrument only. And you want to become comfortable with the anatomy. You need to know where the, where you are in the gland right now. So, and the first initial goal probably is to take a single chip. I think that is where we are going to start today. But then as you proceed, there'll come an early phase, maybe in about 10 to 50 cases, where your goals would be to become comfortable with the movement, to be excellent with the hemostasis so that the patient outcomes are good. And you will be able to almost resect the entire lobe or maybe a small prostate also in about 10 to 50 cases experience. Then as you move ahead to 50 to 200 cases, there will be an intermediate phase where you will refine your motor memory for complicated movements, because you will realize in the end of the presentation that it is not just a single movement of the to and fro movement of the resectoscope. There are so many movements which are involved, the scope dipping down, the scope dipping up, and so many actions happening at various joints. We'll talk about them as well. And then you will be able to basically resect an average prostate with very less complications. And then there's a pro phase when you've done many cases where you basically are doing natural complicated movements with very fast resection. You're mindful of all the complications. You're quite comfortable with the anatomy. And there you can basically resect any size of the gland, because now we have so much technology available to do that. So I always, get back to the time on when I really miss the time when we're actually doing this kind of a thing, the hands-on teaching. I was, taking the hands of the residents in my hands, and we had the instrument together, and then we could really, demonstrate those movements in person to each and everyone. But till that time, let us at least prepare you. So we'll be talking about certain anatomy, the instrumentation basics, chip taking, the technique of resection, and we'll be giving some personal suggestions. So coming to the anatomy, basically we know that the arterial supply is at 2, 5, 7, and 10 o'clock. So these are the places where if you can resect in time, you will be able to make the resection almost avascular. And you have to understand the sphincter in particular, because that is the dangerous complication. So sphincter is basically below the prostatic urethra. And it basically, if you see, the sphincter is very thin in the upper part, or you can say the 12 o'clock position from 11 to 1 o'clock. So there you have to be a little away from the verumontanum, the standard landmark. And you have to understand how to plan your resection. So you should know how to grade the prostate. So basically, you can use the length of the prostatic urethra for the grading. You can have a look at how the lobes are meeting each other and kissing together in the midline. You can also have an idea by knowing how much the intravesical protrusion of the medial lobe is, so that you can plan your resection. You can plan how much time you have to give to what activity of the resection. So basically, here are certain tissues which you will meet when you do the TURP. So the common thing that you will see is, of course, the adenoma. So once you resect the adenoma, what you will be seeing is a burnt bread appearance. So till you have the burnt bread appearance, it means that you're still in the adenoma, and you have to keep going deeper and deeper. Then there'll be certain places which will be hard, especially in the anterior part, where you are basically looking at fibromuscular hyperplasia. Whenever you reach the capsule, you'll be able to see that there's a pink and pliable kind of a sheet or a membrane, which, if you cross this, you're gonna enter the venous sinuses. Sometimes you will perforate, you'll find some shiny yellow fat, which will be loculated, and you will know that you don't have to go to this depth ever again. Then you'll also be encountering sphincter fibrosis sometimes. I hope you don't, but that will again look like some sort of a crisscross fibers with relatively muscular structure. You will be also able to see bladder muscle fibers like the one here, and usually they are circular, running horizontally fibers. You can see tumors, you will find ejaculate duct, and when you sometimes resect the seminal vesicle, you will find that brown epithelium of the seminal vesicle. You will see calculi, hematomas, corpora, myelatium, venous sinuses, arteries with pumpers, and ricochet bleeding also. So these are the things which you will see, and you have to understand to visualize all of them one by one, so that you know where you are and what you are cutting. Now, Rishi sir has already talked about instrumentation. I have to tell you just one thing, because we're talking about the technique, and in technique also we should know how to select our instruments. So you should keep everything available around you. You should have a litho class, you should have a OIU knife, as sir has told. You should have roller ball electrodes, a cold knife, or Collins knife. You should have working elements, maybe of both types, if you're comfortable with them. You should have different sizes of the sheet. Sometimes the urethra is very fine, and it may not be possible for us to use a 26 or a 27 sheet. So basically, we have to keep everything that we are anticipating as a complication and as an added thing, which I think Nikhil sir would be talking about, on the trolley itself. You cannot shout at the staff at the last minute, why is this not there, where is that particular thing. So all these are part of the technique only. So as Dr. Rishi has told, that we are using now the continuous rotating sheet. Now, one small thing that I wanted to add to what Rishi sir said is that the continuous rotating sheet, it has a single inner sheath. So there is no inlet or outlet in that sheath. So basically, if you have a narrow urethra, then you cannot put that 26 French assembly inside. If you had the inner sheath, which was basically a continuous non-rotating, then you would have a inflow and oblique outflow channel in that sheath. So basically, there's one disadvantage of this continuous rotating sheath, which is that you cannot use this inner sheath independently. Whereas in the other models, you could use the inner sheath independently. This is a very important point from the practical aspect also. Now, obturator we've already talked about, and sir has said that Schmidt visual obturator is the right obturator for you. Now, in the exam, they will put these two working elements in front of you and ask you to choose the passive one. So I think you should know about this small trick. So whenever there is this P sort of a thing, inverted P, you can see that it's a passive instrument. And whenever you can see this A forming here in the working element, then it's the active element. Now, basically, I always ask my residents while we're talking which element you would want to choose. So passive is something that most urologists have been buying, because you can do an OIU easily with it, more safely. It's safer for the beginners because the loop is always inside, as Dr. Rishi told about. So, but some people, say that active is better because you can do faster cutting, you have more control over the cutting. So this is something which is debatable, but you should know what are the advantages, disadvantages of the various elements. And of course, the thinner sheath is less traumatic, but you will be able to take only thinner chips or smaller chips. So bigger resectoscope sheath is better only if the urethra can allow it, of course not at the cost of the urethra. Again, monopolar, bipolar we've discussed. How to evacuate, these are the things that I think Rishi sir has discussed. So now let's come to the right topic, which is taking the chip. So the ideal chip has to be this cano-shaped chip. So initially you're going to dip inside, you're going to make a dip inside, then you're going to resect, and then again you're going to dip out. So what you're going to get is, once you dip inside, you're going to get this initial dip, and then the straight parallel lower part, and then you're going to dip out. So this is how the chip looks. Now, when you're cutting a chip, there are various ways of cutting a chip. One is that when you're cutting with a predetermined endpoint. Now, with a predetermined endpoint, you usually use this when you're close to the value. You know that you're not going to go beyond this. So what you do is you place your resectoscope at the level of the value, and then you start cutting from wherever farther you can go, and bring your loop back. When you are basically in the middle of the gland, and you don't want to cut into the bladder neck too deep, or you want to preserve the ureteric orifices, then you can use the cut with a predetermined starting point, which means that you know where you're starting, but probably you exactly don't know where you will be ending, but there's a lot of space, so you can kind of have some margin to extend the cut. Then there is a combination of the two, where you make the initial cutting point, and then you bring out not only the loop, but also the entire assembly. Your entire hand will be coming out like this. So it will be an extended cut. Then there's a retrograde cut, where you are, cutting in the opposite direction. This is dangerous, but pros can of course use retrograde cut to their advantage. Then there's excavating cut. So when you're trying to cut too deep, then it becomes kind of an excavating cut. And then there's an entrapment cut. Entrapment cut means that you are basically engaging that particular structure in the loop only, and then you're basically cutting that structure. So these are things or techniques which you should know about when you're taking a chip. Now, basically, these are the movements which are happening during the resection. So if it's a simple cut, what we are doing is basically, first we are making a movement from the passive element in the thumb, and so we are dipping in deep, we're making that movement on the loop, and then we're dipping out. With an extended cut, what we're doing is, first we are making a dipping in from the shoulder joint and the wrist joint, and then we are using the thumb or basically the hand to come out depending on the element that we have. And then basically again at the shoulder joint, we're going to move it all back so that we can, pull the entire assembly backwards, and then again complete that cut with thumb, and then shoulder joint and wrist joint to bring it out. So dip it out. So we will be discussing about dipping in, dipping out in the next slide. But the movements are not just happening at the thumb or at the finger level. They are happening at the wrist, because we are elevating here like this, the resectoscope, and it's also happening at the shoulder, because then we are basically trying to pull the entire assembly out sometimes to make an extended cut. Similarly, for retrograde cut, what we're going to do is we're just going to use the thumb initially to push it inside, and the wrist joint to bring or dip it out. Similarly for entrapment cut. So basically you have to understand that it is not single movement which is happening, it is a combination of movement which is happening. And as you kind of keep doing this movement, you will understand the basics around it, the tricks around it. So when we are taking a chip, there are two ways to take a chip. One is by releasing after scooping, and the other is that you engage the tissue inside the sheath only. So when you are scooping, basically what you're doing is that you are bringing the scope like this. I will just use a pen to demonstrate this, that so what happens is you're basically dipping first inside, and then you're making the cut like this, and then you're dipping it out. So if this was the prostatic tissue, so basically what we're doing is we're going first inside, then we're cutting, and then we're raising the bar again by using the shoulder and the wrist joint, so that the tissue is disengaged from the loop. So this is what happens when we are using a scooping cut. So it's a complex movement of all the three joints, and the fulcrum is actually at the BM junction. Now this is a very good because it prevents the damage to the scope. So what we are doing is we are not letting the sheath come inside. We are cutting it before the sheath comes inside before the loop comes inside the inner sheath. The other technique is releasing by engagement into the sheath. Now here basically what we're doing is we are letting the entire loop come inside the sheath. So whatever tissue is there, it is cut at the junction. So, but then you have to make sure that the loop angle remains correct, because otherwise, it can cause damage to your endoscope. Now, basically in the resection technique, we already know that it's a lithotomy position, and we have to first calibrate the urethra and see if we can safely put the sheath in. You can use the right fluids based on the type of cautery, and the height is usually at 60 centimeters. Now, basically, there are hundreds of resection techniques that there are, but I would like to just talk about three main techniques. So one is the Nesbitt technique. Here, what we're doing is we are cutting from the upper part first, and then what we are doing is we are letting the lobe fall down, and then we are making parallel cuts on the lobe so that we can basically completely remove the adenomatous tissue. The second technique is the Barnes technique, where basically what we're doing is first we're making a floor so that the outflow improves, and then one side we're going clockwise, the other side we're going anti-clockwise, and we are removing the adenomatous tissue. And then there's the Alcox and Flox technique, where we are basically removing the tissue in quadrants. But whatever be the technique, the principle is the same. First, what we do is we make a cone so that the outflow improves. Then we excavate deeper inside the adenomatous tissue, and lastly we take care of the apical part of the prostate. So basically, this is just to give you an idea. So first we made the cut here. Now the entire lobe, when we made this cut, is that lobe falls down. Once it falls down, we are basically going to make serial cuts, after the other, and we're going to remove one lobe. Then we start with the second lobe. So always try, especially if it's a big gland, that finish one lobe first. Because sometimes you may just cut everything and it will just start to bleed, and patient also will not get the benefit, and you will also end up in a thick trouble. So remove one lobe first, let the hemostasis be complete for that, then start the other lobe.
Raman, please.
So I'm now going to summarize. So just some personal suggestion that I wanted to share is that if there's a large gland, you can use some Lasix. Make sure that you use physiological fluid like saline if you have bipolar. Prevent the capsule perforation. Reduce the intracycle pressure if required through a continuous flow or a Reuter's cannula. For lubrication to prevent strictures, use a Neosporin ointment or Vaseline, because sometimes the jelly dries off. And if you encounter bubbles, just turn the scope upside down or do a dome-directed drainage, and avoid using cautery near the bubble. So with that, I again thank you, and over to Rishi sir now.
Thank you, Raman, for that elaborate presentation. Next, we have complex situations in TURP by Dr. Nikhil. Is going to tell us how to tackle those specific particular complex situations and the final points of it. Nikhil, can you share your slides? Nikhil, Dr. Nikhil? Yeah. Please unmute yourself also.
Hello.
Yes. Please go ahead.
Hi. Good evening, everybody. Thank you, Rishi and Raman. Thank you, USI, for giving me this opportunity. So we'll be discussing about some special situations in TURP. We touch upon some special situations. We'll begin with a large median lobe which precludes visualization of the ureteric orifice, like this. If the median lobe is large and you are not able to see your ureteric orifice, you have to start resecting, taking chips one by one from the top of the median lobe, and when a thin slice of it remains, with a passive loop you can sort of turn it over and roll it, and then visualize the orifice, and then be certain of your further cuts. Then at times there can be an overhanging adenoma, where the adenoma overhangs the verumontanum, and you have to be very sure not to injure the membranous urethra. And then you can use the retrograde technique, where with a passive loop you push the overhanging portion up and then mark your cut, and then take small passive cuts, making sure you end in the resected area that you have done the resection up to the middle lobe. And then you can resect that overhanging portion and be sure of the security of the membranous urethra and the sphincter. Then a word about very large adenomas. Although the technique remains the same as Raman just told, any one of the technique can be used, But when we are resecting very large adenomas, the duration of operation and the quantity of tissue removed is directly related to the blood loss, the fluid absorption, the metabolic complications, and stricture rates. So initially, one should not attempt resecting glands larger than say 60 to 70 grams and slowly evolve from there. And if there are very big glands, then one should resort to either a retropubic prostatectomy in a single session rather than a multiple TURP or maybe a HOLEP also. Resecting very small glands is also very tricky. Why I say this is because there is an up to 20% incidence of bladder neck stenosis or contracture after TURP in small glands, which are less than 30 grams, and up to 7% in glands which are between 30 to 60 grams. And that may be related to excessive or circumferential resection and use of maybe a little larger resection loops, which can generate excessive heat leading to scarring. This is known to occur in small prostate glands after both monopolar and bipolar TURP. So adenoma weight was an independent risk factor for bladder neck stenosis, and usually it presents within 6 months in up to half of the cases and within 2 years in almost all of the cases. Addition of a TUIP procedure to TURP in prostates less than 60 grams, because it was seen when initial studies were there between for very small prostates less than 30 grams, it was seen that when comparing between TUIP and TURP, they observed that when we do TUIP, there is a very less incidence of bladder neck stenosis. So now it is recommended that in glands which are between between 30 to 60 grams, although TUIP is a recommended procedure for glands less than 30 grams, but even for glands up to 60 grams, after you do after you do a TURP, add TUIP to prevent stenosis. It has been shown to reduce significantly the incidence of bladder neck stenosis. Then at times there is a bladder tumor along when you enter for your TURP, you find a bladder tumor, or maybe at times you know that there is a bladder tumor and patient also has a bladder outlet obstruction. So it has been seen that there is no increased risk of bladder tumor resection recurrence either at the bladder neck or urethra or progression of the bladder tumor after simultaneous TURP and TURBT as compared to TURBT alone. Most of such studies have been for tumors less than 3 centimeters, but some studies are even up to 4 centimeters. And some studies have even noticed that there is in fact a decreased risk of recurrence, maybe because of resection of simultaneous carcinoma in situ, which was present at bladder neck in 12% of patients with bladder tumor. Although this is a non-significant thing, but still definitely there is no increase in risk. So it is a safe to go ahead with bladder tumor resection and bladder and TURP. Then bladder diverticulum, big huge diverticula, more than 1/3 size of the bladder or like that, they have to be dealt separately by open or laparoscopic techniques. But for small bladder diverticulum, if the diverticula are very wide mouth, they can be left as such. But otherwise, at the end of resection, you should evacuate a narrow mouth diverticulum with all the chips and then make an incision at the neck of the diverticulum, which should be deep enough to widen it and convert the diverticula in the new area of the bladder wall. Then sometimes we have a situation that our prostate TURP patient, BPH patient is there with a bladder calculus. So is it mandatory to resect the prostate in a man with bladder calculus? What is causing the symptoms? One should try to ascertain whether it is a stone or the prostate that is causing symptoms. That can be, you can get some hint about it when you take a detailed history. You get a uroflowmetry, the number of calculi, how many are there, residual urine, how much is the residual urine. That may help in segregating this. There are two prospective, this study, there is a beautiful study with two prospective arms of 32 patients each with CLT alone versus CLT plus TURP. And at intermediate follow-up of 29 months, 1/3 of patients in CLT alone group required TURP for indications such as stone recurrence or retention or recurrent UTI. In larger retrospective series with a longer follow-up, this figure goes up to 2/3 of patients. And only very high PVR is directly associated on multivariate analysis with a further need for TURP. So patients where the calculus is there, simultaneous TURP and cystolithotripsy may be required. So it is reasonable and safe to deal both with stones and prostate, especially if stones are less than 3 centimeters and prostate is also a moderate size. And if you are able to keep the duration less than 90 minutes, that is considered the safe duration, 60 to 90 minutes. Prolonged durations of urethral instrumentation is associated with higher incidence of urethral stricture. Use of a 26 French nephroscope and pneumatic laser lithotripsy is superior to using standard lithotripsy cystoscopy accessories for bladder stone fragmentation. If the stones are bigger, a percutaneous cystolithotripsy should be used, and which should be followed by TURP in the same sitting if you are able to finish the stone in reasonable time. And this is a study where a simultaneous PCCLT using fragmentation in a laparoscopic entrap stone was entrapped in a entrapment bag, and PCCLT was done by one surgeon without disturbing the other surgeon who was doing the TURP, and they used it to effection. And maybe once you gain more experience, you can and you have a good partner, you can experiment with these things also. These will evolve. Then at times there is a situation where patient develops intraoperative penile erection, which can occur with regional anesthesia in up to 2% of patients. Erection develops on stimulation, maybe while part preparation or initiation of cystoscopy, and it happens due to autonomic imbalance and unopposed parasympathetic stimulation. Many techniques are used. Prompt intravenous ketamine can be given, which is seen to observe detumescence in up to 77% patients, or ultra low dose intracavernosal adrenaline can be given, or other agents like norepinephrine, phenylephrine have also been used. 8 puffs of salbutamol aerosol through the tracheal tube has also been used. But however you do it, early intervention and has been emphasized in all of the studies in these cases, which is a critical factor for successful detumescence. Otherwise, it can lead to fibrosis, especially thrombosis and later fibrosis, and you may have to postpone your procedure. Then there can be at times incidentally diagnosed stricture. One should only treat the stricture if you happen to see a stricture when you are attempting a TURP. You have gone in with the intent of TURP. One should only treat the stricture and not proceed generally with a TURP, however tempting it may be, because generally it is a stricture that will be causing the symptoms. And although I will say that an attempt should be made preoperatively to rule out any stricture by either RGU or a calibration of the urethra. You should not land up in such situation. Then at times your patient will be having a cardiac pacemaker, which may interfere with the function, resulting in bradyarrhythmia, asystole, or ventricular fibrillation. It has been seen that asynchronous fixed frequency pacemakers are generally insensitive to the cautery higher external frequency current that is generated by our monopolar cautery. So reprogramming the pacemaker to an asynchronous mode as may occur following the application of a magnet, but generally this can be done now without a magnet. The pacemaker person, that guy comes from the company and changes the mode to the asynchronous mode, and that mode is changed to a rate greater than the patient's underlying rate. Bipolar energy may be used with minimal interference with pacemaker circuit, but does not altogether prevent it. So the same precaution has to be taken even with bipolar. Pacemaker and resection circuits are less likely to influence each other if they are further apart and physically separated. That is why the return electrode should be applied below the mid-thigh in such cases. And because the pacemaker is set to an asynchronous mode, now all safe practices for resection should be adhered to, because any fluid overload should be avoided for this patient's heart now, and the procedure should be completed in due time with all safety measures that we take. Then lastly, uh, uh, earlier it was taught that perineal urethrostomy is an adjunct, is at times required, and may be required for resection. Whether still there is a role, definitely at times it may be required, especially when morbid obesity or maybe a very long penile urethra. Sometimes body contractures will not allow transurethral resection, and you may have to make a perineal urethrostomy just for doing a TURP. And at times maybe a previous rigid penile prosthesis may also preclude a TURP, and you may have to do a perineal urethrostomy. This is from this paper where a perineal urethrostomy was made, and this is 3 months after the perineal urethrostomy that it has healed and without any stricture, and it is a safe procedure. At times it is more often required. I have used it once for a bladder tumor at the dome where it could not be reached. So yes, that is all I think of presenting to you. Thank you. I hope it will be useful.
Wonderful, sir. Wonderful, Nikhil, sir. It was enlightening for me also. Similar situation I also faced for a dome bladder tumor. Perineal urethrostomy was helpful. So, sir, with this enlightening talk, I would now request Dr. Prabjot Singh, sir, to talk about the complications that can arise out of TURP and how we can prevent them, sir. So many of those questions have already have been asked around it. So, sir, I think this talk will make us all more wise. Over to you, Prabjot, sir.
Thank you, Dr. Raman, Dr. Rishi, and Professor Arun and Professor Keshav, and ISU for giving me this opportunity. I hope my slides are visible, Dr. Raman.
Absolutely, sir. Absolutely.
So, I know this is a dinner time and everybody is being restless. So during this restlessness, always the complication happens. So we need to talk. I'm going to talk about the complication of TURP and prevention and management. As there is a famous quote that the eyes sees what our mind knows. So we should be knowing this complication of TURP before jumping over to the procedure. I divided the complication into two parts: perioperative, which include the intraoperative and the immediate post-operative, and then the delayed complication. Starting with the perioperative complication, the most common and the most dreadful complication for any surgery is the hemorrhage. And this is the literature from the old literature which says the operation need to be stopped and may require the patching of the prostate in almost 0.5% of the patient. And blood transfusion may be required in 4.4% of the patient. So how should we control that? The hemorrhage can be divided into unrecognized arterial bleeding. I'm talking about the intra-op bleeding, small venous ooze, or sometimes there is a open venous sinuses. To diagnose arterial bleeding, it is always bright red in color, and it is pulsatile. You will not be any difficulty in diagnosing it. Whenever you diagnose the arterial bleeding, you can apply the coagulating current directly over the bleeder. Sometimes there is a thick, large artery in which you can compress your loop over the surrounding tissue and try to coagulate the vessel. As Dr. Raman's slide was showing that there may be some ricochet bleeding. That means there is a bounce bleeding. If you are seeing the bleeding coming, but you are not able to see where the source is, at that time you can see the opposite side of the clock. Like you are seeing the bleeding at the 10 o'clock, then you have to see at the 4 o'clock because of the ricochet phenomena. Sometimes there is a bleeder and sudden there is a red glow over your vision. You are not able to see anything. At that point of time, you can advance your scope into the bladder and then angulate and bring back the scope slowly and try to visualize the bleeder, and then compress the vessel, and you can identify the bleeder and pinpoint coagulation can be done. For the venous bleedings, there are small venous oozes always happens. And you can slow the irrigation in between or the end of the surgery. When you are slowing the irrigation, you can see those small veins. Usually they happen at the over the bladder neck or over the apical tissue. Then you can pinpoint coagulation can be done in those areas. For the venous sinuses, if you cut very deep to the capsule, you can expose the venous sinuses. These venous sinuses have a very thin wall, no muscularis, so it is sometimes difficult to fulgurate these venous sinuses. It's better not to open them, and always take preventive measures. At the end of the procedure, for the small venous oozes, you can put a catheter with a 35 to 40 ml of saline in that balloon and give the bladder neck traction for the 6 hours, which can take care of all the venous bleeding. At the end of the procedure, you should always check the blood pressure, or you can ask your anesthesia colleague about the blood pressure, because if the patient is in hypotension, the small bleeders will not be opened up at that time of your closure of the procedure. So immediate hemorrhage, which can happen into the recovery room because of some small clots, or the chip can block the catheter, leading to the clot retention. Usually it can be managed well with the saline irrigation, but sometimes it is too many clots, so patient needs to be taken back to the operative room, in which you have to evacuate the clot. Then you have to systematically examine the prostatic fossa where exactly the bleeding is. Sometimes there is bleeder at the 12 o'clock position, which is usually missed during surgery, and sometimes there is a rare open exploration may be required in case of dreadful bleeding, which is will not be able to control with the endoscopic procedure. In that, you have to open up the bladder, then see the prostatic fossa, fulgurate the bleeders. You can give the circumferential neck sutures, and sometimes, very rarely, you have to pack and come out after come back after 48 hours. So these are the questions which examiner used to ask in the exam. So what is the prevention of this hemorrhage? Prevention is, you, as Dr. Raman said, you have to go very systematic. You should not be jumping from one lobe to second lobe without taking care of the first lobe. You have to you should be having good hemostasis in the first lobe, then jumping to the another lobe. And follow the one technique. You should not be using so many techniques. You should stick to the one technique. The difference between open prostatectomy and the TURP is in open prostatectomy, you always go between the prostatic adenoma and the capsule. So there is a single vessel you can control at the base of the capsule. But in TURP, you have to cut again and again the same vessel again while taking the chips. But my personal advice to you is, during the early career, you should fulgurate whatever comes in front of you. So at the end of the surgery, you should check fossa and apical area for any ooze. Traction should be given. Irrigation fluid should be clear and light pink before you shift the patient outside. And the drainage should be smooth. There should not be any jerky drainage of your Foley's catheter. And always go and check the irrigation in the recovery room. Delayed hemorrhage, this is another complication which can happen within 4 weeks. Some hematuria is always there after 4 weeks. So if it is associated with the dysuria, fever, so UTI should be ruled out and treated with the antibiotics. As the Blandy says, the carpet slipper convalescence for the next 2 weeks. That means the person should be wearing carpet slipper and should be at home, should not be doing any strenuous exercises or doing their job at least for 2 weeks for the same reason. You can ask the patient to take increased fluids as well as laxatives to prevent the recurring hemorrhage. TUR syndrome, I know this is now like a history. It is in the era of the monopolar TURP. The incidence was 2%, now it is 0.8% only. And the pathophysiology is either fluid overload because leading to dilution of hyponatremia, which disturbs the membrane potential, leading to the cellular edema. And normal patients usually cope up with the diuresis, but the patients who are compromised like CHF or CKD, or the patients having SIA, DH, who are not able to have the diuresis, proper diuresis, those patients can go into the fluid overload. Initially, we used to use glycine in the monopolar TURP. Glycine itself is an inhibitory neurotransmitter which can produce ammonia, leading to the liver toxicity, and hyperoxaluria causing kidney toxicity. And once the TUR syndrome happens, the main pathology is the lower sodium. Sodium becomes less than 125 or less. So why there is absorption of the fluid? Usually, as Dr. Raman said, we usually keep the solution, our irrigant at 60 centimeter of height to have a good vision. For with that, the intravesical pressure is around 5 centimeter of water, and venous pressure is always, venous channel pressure is around 10 centimeter. So if you increase the height of the fluid from 60 to 70, there is an increase in the vesical pressure, leading to the absorption of the fluid into the venous system. Or so there is a perforation of the venous sinuses during resection. It can cause the fluid absorption. And initially books used to say, even in the Campbell, they written that gland more than 45 gram and the duration of operation is more than 90 minutes, then this may be the cause of the TUR syndrome for the prolonged fluid absorption. In TUR syndrome, patient may present in the various features like hypertension, bradycardia. If the patient is spinal, he can say that there is flashing of lights, visual alteration. This is the first clue the anesthesia people can get from the patient. So we should be vigilant. If the sodium goes very low, it may lead to even the cardiac arrest and the ECG changes. So the treatment of TUR syndrome is you have to be very vigilant during surgery, and once you suspect there is a this TUR syndrome, you should send the sample for the sodium either intraoperatively or the immediate postoperatively and start giving the Lasix. For the sodium replacement, you have to first use the for the sodium, you have to calculate the sodium deficit. There is a formula. You have to target the sodium like 125 minus current serum sodium into the body weight into 0.6, that is the body surface area, and then calculate how much sodium you have to give. In the severe cases, you may need to give the hypertonic saline, but as soon as the patient stabilizes, you can shift to the normal saline. There should not be rapid correction because it may lead to the osmotic demyelination syndrome. So how to prevent it? As Dr. Raman and Dr. Rishi said, there is a low pressure irrigation system now very well available. There is a continuous sheath available which keeps the bladder pressure very low. Or you can use the SPC cannula also. Keep the irrigant fluid at around 60 centimeter. Don't make it 70 or 80. Try not to make open the venous channel. Resection time should be less than 90 minutes, and you can use the bipolar saline, which has almost no TUR syndrome. Then next is the subtriangulation. It happens because of the overzealous resection at the neck area between 5 to 7 o'clock position. The only problem is during resectoscope, sheath beak may go in between the bladder as well as the rectum. That may create the problem. Or your catheter while putting may go into that plane. So to prevent that, you should take during the section, if it happens, you just make a good hemostasis and complete the procedure. And while putting catheter, you can put the catheter, three-way catheter over the guide wire and put a finger in the rectum, which will help them putting catheter properly into the bladder. Bladder perforation can happen because of the careless resection or the partially distended bladder. Sometimes it's difficult to diagnose in the GA, but the patient in the spinal, he may start having a respiratory problem or the abdominal distension, he may complain, or the pain. You can diagnose it with putting an ultrasound probe or doing a cystogram. With the small perforation, extraperitoneal, you can put a catheter and come out, or the large perforation, you may have to do the laparotomy. Similar to the capsule perforation, prostatic, if you not able to diagnose, recognize the circular fibers, you may go deep and leading to the capsule perforation. Again, if it is a large perforation, you may have to open up the patient, or if it's a small perforation, you can just put a catheter and come out. Rectal perforation can happen if you are not aware, you are very aggressive in resection at the posterior part. And if there is a big hole, then you have to involve colorectal surgeon, and you may need the bowel diversion as well as urinary diversion. Resection of orifice can happen during careless dissection. If you have resected the orifice or you coagulated the orifice, you have to put a stent and come back and do the imaging after 4 to 6 weeks. And the prevention is better to visualize the orifices before starting the resection. You have to make in mind 3-day picture should be made in your mind that where exactly what is the distance between the bladder neck and as well as this orifices. If you are not able to see, you can use 70-degree lens if it is available. You can ask your anesthesia people to give methylene blue or indocarmine. Check the lamp during surgery. Also, you have to check orifices regularly. If there is a big lobe, like Dr. Nikhil said, you have to cut slice by slice to prevent the ureteric orifice injury. But in the cases, I always advise my resident to give pyridium in the pre-op period so that I will be able to immediately diagnose where the orifices are once the middle lobe is done. If the orifices are very near to the neck, only cutting current should be used, not the coagulation current. Intravascular, sorry? Intravesical explosion can happen. I have seen in my career too. I have seen 2 cases in which there is a sudden explosion and blackout because of the H2 gas production as well as oxygen, and there is a current flowing inside. So in those patients, you have to explore the patient and then repair the bladder. You have to check bowel also carefully. Priapism, Dr. Nikhil has covered. Fever can happen in the post-op period, so prevention is always give pre-op urine culture should be sterile, and pre-op antibiotics are very essential, especially in those patients who are on catheter. To prevent the hypothermia, you have to put the patient on warm blankets, warm irrigation solution, or warm IV fluid should be given to the patient. Delayed complication failure to avoid can happen around 6-7% of the patient. It may be because of inadequate resection, tissue edema, because of the issue with the contractibility of the bladder. In those cases, you have to catheterize the patient for 1 to 2 weeks. Edema will settle, and then you can give the catheter fluid trial. If fails, then you have to do the urodynamics in those patients. Stricture also can happen if you use large Resection sheet, or patient is having had prolonged traction. In those patients, maybe substitution urethroplasty may be required in the future. Bladder neck contracture can happen. Dr. Nikhil already discussed. In treatment, you can put a guide wire. Usually there is a small hole. You can identify pinhole. You can put a guide wire and then dissect at bladder neck either with a laser or with the cautery at 5 to 7 o'clock position. Or in recurrent cases, you may have to do the YV plasty. Incontinence can happen. For the incontinence, if you are for the prevention, you have to take care of the sphincter. You should do the Nesbitt sign intraoperatively to identify the sphincter. You should respect the verumentanum, and you should not be operating during priapism. Sexual dysfunction can also, it's very common. Impotence can happen because of the injury, because the cavernous nerves run very close to the capsule at 4 to 5 o'clock position and 7 to 8 o'clock position. So should be you should be very careful and discussing this with the complication with the patient preoperatively. For retrograde ejaculation, you can preserve the area around 1 centimeter proximal to verumentanum, and people have seen that retrograde ejaculation is almost nil in those patients. So my take home is prevention is always better. Always plan before the surgery. Go systematic. Remember the landmarks. Learn from other mistakes. Don't do your mistake and then learn. I recommend these 2 books you should be reading during your residency. One is Blandy Transurethral Resection and one is Mormer Transurethral Resection. Thank you.
Thank you, Dr. Prabjot, and I would like to thank all the participants and faculty who have so eloquently brought out all the issues of TURP. I know we can go on and on for a procedure which seems otherwise so simple, but if we can take 1 or 2 more questions with the permission of Dr. Chawla. So can we, do we have time?
Yeah. There is, you can see in the chat box, there are a few questions if you can answer live.
So there is one question, maybe Dr. Prabhu, if you can take, is there any ideal catheter indwelling time after TURP, and why so? All the faculty can please unmute themselves.
Ideal time is only usually put a catheter for 48 hours. And if the patient is allergic to latex, then we can use the silicone catheter. More than that is usually not required.
Yes, it's correct. See, the lesser the time with the catheter, the better it is. Ideal would be having no catheter, but if the patient has a clear urine for about 6 hours or so, one would like to remove the catheter. And but because of all practical purposes, we generally tend to remove the catheter the next morning once the patient has a clear urine for more than 6 hours. This next question is, who will take that? Raman, can you take that? Is there any role of dutasteride after TURP?
So, sir, practically speaking, we don't use it anymore, but the proponents for that, it would make the gland less vascular. And since people say that, the gland tends to grow because we're leaving adenoma, some of the adenoma behind, it can reduce recurrence, but I don't think that we can recommend it on this.
Yes.
It should not be used.
Yes, correctly said. There is no actually role for the perioperative bleeding. People do use it preoperatively for 3 to 6 months to reduce the size of the adenoma and possibly less bleeding. But even that is controversial. But definitely there is no role in the perioperative bleeding. Nikhil, there is one question for you. If one has a large stone, vesicle stone, along with the prostate, which should be tackled first and why?
Yeah, I answered it in the chat box. The stone should generally be tackled first because after TURP, it is unpredictable generally how the vision will be and how long will you be able to do. So the TURP has to be later and stone has to be first, and then depending on the time how much is remaining, then you can take up the TURP.
Yes, very clearly. See, sometimes the prostate itself is so large that one may not be able to see the stone because of the large median lobe. In those cases, maybe one can resect the median lobe, and depending upon the size of the stone, one can either tackle the stone first or maybe do it at a later stage.
Yes, as soon as you have the instruments mobile enough to do that.
Yes. So there is one last question, which is the role of traction after doing a TURP, and what is the ideal duration for that? Maybe I can answer that. So as long as one can achieve a good hemostasis at the end of the procedure, which means there is no to minimal bleeding when the inflow of irrigant is minimal, then one does not require any kind of a traction. It is the balloon of the catheter should be snugly fit, and it should be only a gentle traction. No strong traction should be used. Only in cases where you are not able to achieve good venous hemostasis, arterial bleeding should always be tackled on table. If you are not able to achieve good venous control, then maybe you can use a little stronger traction, but in any case, going beyond 4 to 6 hours is not advisable. So I hope we have also answered all those questions, and I would thank my faculty once again who have participated, and I once again thank USI and ISU for giving us this opportunity to be with the residents here on this platform. Thank you, sir.
Thank you, Rishi, and thank you, Raman, for this session on TURP module. I think all the faculty in both the modules did a very good job. The presentations were very descriptive and very informative. Not only they covered the simulation part of that, not only they covered the instruments part, but showed the procedure also, the tips about the procedure also. And I think residents would have got a great benefit by learning experience from all the presentations. I think Dr. Keshamurthy is not available. He is busy in some other call. Before I hand over to Dr. Rajiv Sood for his concluding remarks, a kind request to everybody. Tomorrow is another day for two modules. One is a very common procedure as flexible uterinoscopy, and the other is laparoscopy with some mention of the robotic simulation module also. Faculty have prepared excellent presentations, all the video-based presentations. I urge you to stay logged in for tomorrow's 2-hour program of the UROMET, the second day. With this, I hand over to Dr. Rajiv Sood. And I thank all the faculty for the good presentation and all the viewers. Thanks to Navneet and Mrs. Kiran. And over to you, Dr. Rajiv, for your concluding remarks.
Thank you, Dr. Chawla. This was a wonderful day. And for the first time, this was the virtual UROMET program. As I told you, that simulation is not only on the models of mechanical nature. It can be simple, it can be mechanical, it can be the standardized also, and it can be virtual also. And it is not necessary that we are doing for the operative procedure. Simulation, as per definition, can be on the basis of a clinical scenario also. And there should be a pre-test and post-test. Like today, residents have participated. We will plan now after this introductory sessions of UROMET. In future, we will introduce the pre-test the knowledge level and other understanding of all the residents, and then we will do the debriefing session like we were doing in OSCE also, and which was conducted first for the andrology, and Dr. Raman, who is here today also, he conducted that, and after that you discuss that and you debrief and you conclude that what is there, and then we go for their latest understanding. So that is the real purpose of simulation programs. That is the competency test. After that we will be doing, and we will be doing everything systematically in case we are not able to do the actual physical UROMET program. So this is a new version, and this pandemic, COVID pandemic, has given us opportunity to deal with every kind of situation, and we are not letting any moment go waste. Education in urology is on wheels, and we are leaping, and we are doing some certain things which the others are not even thinking. So this was the great idea. Dr. Keshav and Dr. Chawla, they both are to be congratulated, and all the faculty and also the participants of these two modules, they are to be congratulated. We'll have many such programs in future, and we are meeting tomorrow morning for another two modules, and with this discussion in mind, Dr. Chawla, I will request you also that before UROMET, because what are our objectives? Based on that, we will frame our questions. And after our faculty is framing the questions, that what they want to teach, what are the objectives, learners' objectives and instructors' objectives, and whether these objectives are met or not met. And ultimately, this will give the true value of the programs. And I think those residents who have participated, they are immensely benefited with all the fineness of points of all practical and otherwise. And we will be meeting tomorrow morning again for the second day of UROMET. Congratulations to all the faculty and the residents for today, and best to all of you for tomorrow. Thank you very much, and good night for the time being.
Thank you, sir. Thank you, everyone. Thank you. Stay safe, stay well. Good night.
Thank you, sir.